Rajendra, please come. Come. Uday sir already. Doctor, afternoon meet me. Another outside.
Okay. We will begin by the auspicious lighting of the lamp. So please come forward to light the lamp, sir. Okay. Now I call upon Dr. Nagavali to sing the prayer song.
Om Gurubhyo Namaha. मुदाकरात्मोदकं सदा विमुक्तिसाधकं कलाधरावतंसकं विलासिरोकरक्षकम् अनायकैकनायकं विनाशिते भदैत्यकं नताशुभाशुनाशकं नमामि तं विनायकम् न तेतरातिभीकरं नवोदितार्कभास्वरं नमत्सुरारिनिर्जरं नतादिकापदुद्धरम् सुरेश्वरं निधीश्वरं गजेश्वरं गणेश्वरं महेश्वरं तमाश्रये परात्परं निरन्तरम् समस्तलोकशङ्करं निरस्तदैत्यकुञ्जरं धरेतरोदरं वरं वरे भवक्त्रमक्षरम् कृपाकरं क्षमाकरं मुदाकरं यशस्करं नमस्करं नमस्कृता नमस्करोमि भास्वरम् अकिञ्चिनार्तिमार्जनं चिरन्तनोक्तिभाजनं पुरारिपूर्वनन्दनं सुरारिगर्वचर्वणम् प्रपञ्चनाशभीषणं धनञ्जयादिभूषणं कपोलदानवारणं भजे पुराणवारणम् नितान्तकान्तदन्तकान्ति मन्तकान्तकात्मजम् अचिन्त्यरूपमन्तहीनमन्तराय कृन्तनम् हृदन्तरे निरन्तरं वसन्तमेव योगिना तमेकदन्तमेव तं विचिन्तयामि सन्ततिम् महागणेशपञ्चरत्न मादरेण योऽन्वहं प्रजल्पति प्रभातके हृदि स्मरन् गणेश्वरम् अरोगतामदोषतां सुसाहितीं सुपुत्रतां समाहितायुरष्टभूतिमभ्युपैति सोचिरात् समाहितायुरष्टभूतिमभ्युपैति सोचिरात् समाहितायुरष्टभूतिमभ्युपैति सोचिरात्. Thank you.
Now I'd call upon Dr. Divya to give the welcome speech.
I take immense pleasure in inviting you and welcoming you for this infection control event today. This is also coinciding with the month we celebrate World Hand Hygiene Day on May 5th. And this year's theme is accelerate together, let's save life, clean your hands. So with that, it is about empowering ourselves to make our hospitals safe for them to go back home without a infection or even getting a hospital-acquired antibiotic-resistant bugs. And if you see this COVID, which has just passed, unfortunately, we had to take the wrath of it. But one good thing which came out of it is it made sure that the knowledge and importance of hand hygiene penetrated deep into not only healthcare, but also into the public, which would have taken us, much more efforts from the medical fraternity if we were trying to get to that kind of awareness. So, which has also projected infection control to the limelight. To keep that momentum going, we thought we will keep this infection control workshop to the basics so that we can give you the fundamentals of infection control program. I don't know how many of you are infection control nurses, how many of you are going to start an infection control program in your hospitals. So we'll just give you a strong foundation here so that you can build your program on top of it. So that is the idea of today's program. But you have to realize that infection control is a big slice of hospital patient safety, and today's event is just going to be a small bite in it. So I hope you enjoy today's events and programs and sessions, and as much as we took the pleasure of putting it all together. Welcome all, and let's start the feast then. Thank you.
Thank you, Dr. Divya. Okay, now I would call upon Uday sir to address the gathering with a few words of encouragement, sir.
Namaste everybody. I welcome you on behalf of the Apollo Hospitals. I see a lot of faces from outside the Apollo Hospital as well. It's very encouraging to see your interest in these areas. First of all, I would like to congratulate the Department of Infectious Diseases headed by Dr. Divya and the medical services headed by Dr. Umesh, who's taken this initiative to push forward this particular event. Infection control, as we all know, is the most important part of our life in the hospitals, and any compromise on this can lead to results which none of us would like to do. None of us would like to accept, none of us would like it to be passed on to anybody. So I wish all of you a very, very happy learning. I'm learning a lot of areas that our teams have focused. Take as much as possible from here and become the torchbearers of infection control. Wish you all good luck. Thank you.
Thank you, sir, for the wonderful words. I would like to call upon Kumar sir, our senior intervention consultant, to say a few words too, sir.
Good morning, and thank you very much for including me in this. All I wish to say is that we all have to learn, and we all have to learn constantly. And a lot of our consultants can do very well with some regular feedbacks from important workshops like this. So I really wish there were more consultants and more younger junior doctors who can take up the mantle and make sure that we prescribe the right kind of antibiotics for the right bugs, which unfortunately needs a lot to be desired as of now. In most hospitals, not just here, everywhere. So I fervently hope that this workshop paves the way for much younger and junior doctors as well. On behalf of the doctors, I'm talking about mainly, I'm sure the nurses are all behind us. Did you wash your hands? And if not, halfway through, they always come back to us, there's a small bottle of sanitizer. So that way they are doing their own work. We also will join hands in helping to make this hospital and all hospitals in future to risk the infection rate and bring goodness and happiness and health to all. Thank you.
Thank you, sir, for the wonderful words. Now I'd call upon Dr. Divya again to continue with the further programs that we have assigned for you today. Dr. Divya, we can start with the
They'll take it off. Take it away. ಇದೆಲ್ಲ ಇಟ್ಕೊಂಡು ಇಷ್ಟೇ ದೊಡ್ಡದಾ ಆರು ಹಾಂ ಇದು ಚೇಂಜ್ ಆಗುತ್ತಲ್ಲ ಇದಾ ಓಕೆ ಇದು ಆನ್ ಆಗಿದೆ ಅಲ್ಲ ಚಿಕ್ಕದಾಗಿಲ್ಲ ಸ್ಕ್ರೀನ್ ಇನ್ನೂ ಸ್ವಲ್ಪ ದೊಡ್ಡ ಮಾಡೋಕ್ಕಾಗಲ್ಲ ಸ್ಕ್ರೀನ್ ದೊಡ್ಡ Good morning, everyone. So today's topic, we thought we'll start off with the components of infection control. Now you have to understand that modern medicine has come a long way in treating conditions which we were not treating before. That includes putting a lot of devices, making more complex surgeries, and using more and more drugs which causes more immunosuppression, like the biologics and the chemotherapeutic drugs used in oncology. The more and more transplants, the department of transplant becoming more and more active, and the use of immunosuppressive drugs. It's never been, I mean, it's probably the pinnacle of, modern medicine right now, and a good time to be sick. But unfortunately, this comes at a cost. Most of these having devices or, making complex surgeries comes at a cost of increased chances of getting an infection. Use of drugs, immunosuppressive drugs, be it for chemotherapy or for transplant, lowers your immunity and probably increases your chances of getting an infection. But that's not even the end of it. We have how much we think we have advanced in other parts of modern medicine. I think, antibiotics, we have reached a null. I mean, we have reached a lull. We don't have any new antibiotics coming in. We are at a stage where we have increased chances of getting infections. And, we don't have enough drugs to treat them. Okay, so probably infections and not unable to treat infection is going to push us back with all the advancements that we have already made so far. So at this point, we have taken a full turn to say that prevention is better than cure, and so having a strong infection control program probably will save more lives who have come for some other issues which needs treatment. They come for transplant, going back with an infection, or even having increased mortality because of it is not the cost they should pay, because we cannot have preventive measures in place. So having said that, as I said, this is what how much we see encouraging. I know this should not be the first slide of this program, but unfortunately this is where we are. And so we have to take the threat seriously so that we can, prevent more infections for our patients. So why do we need a strong infection control program? As I said, patients come for an issue. We should send them back safely. And one of the main factors in patient safety is prevention of infection and antibiotic resistance in them. So having a strong infection control program is associated with decreasing such incidents in your patients. Now, clean, safe care is patients' right, and it's our duty to give them one. Okay, so having infection control program is what protects our patients. Now, these are the 8 components. I have made it as simple as possible. Let's hope in the next 20 minutes I can talk. So the first component is just having an infection control program. The first step is having it on paper, right? So infection control program is usually spearheaded by an infection control team, which at least should have one infection control nurse or a doctor who can look through daily activities. Having a dedicated budget, because there's a lot of resources which are needed for running an infection control program. Having a dedicated budget, having a team and a committee which has members of various departments, other stakeholders, having them getting their input and discussing the interventions taken is also equally important. Access to microbiological laboratory for a good antibiogram to track our resistance, to track where we are standing with isolation. Access to microbiology is very, very important. So having said that, you have a team, but you cannot be just doing something. You're doing hand hygiene. Are you taking care of the devices? Are you doing? No. We need to have set guidelines. We need to have guidelines on which we can base our, base our program on. We need to have set guidelines for each of the work which is being done, and it should be based on evidence-based guidelines from international and national guidelines. And it should be first frame the guideline. Make sure you educate the person who is going to implement it, and then always monitor whether your guidelines are set in place or not. Now, these are some of the guidelines that you need to definitely have, like hand hygiene, how to decontaminate medical devices and patient care equipments, environmental cleaning, healthcare waste management, injection safety, healthcare protection, occupational health, aseptic techniques for any of the procedures, be it in the ICU or in the ward or in the OT. We need to have aseptic technique guidelines on it. Triage of infected patients, where they will go, how to isolate, where, all those things you should have definite SOPs. Next is, once you have set the guidelines, next is teaching. It has to, the end user should know what is expected out of them. So it has to contain, your program should have educational programs on a almost daily basis. It has to be an on-job thing. And it should include a new employee orientation, and the existing staff should be continuously taught the same so that it becomes a habit. See, infection control is more of a behavioral change. You need to keep practicing it to get a hang of it. So for that, continuous education will help, become a habit. See, doing a hand hygiene, all of you automatically wash your hands before, having food. So it becomes a habit. So continuous education and correction from the infection control team is what makes it a habit, and it becomes a part of your daily practice. So to have that behavioral change, we need a very good educational system of of our infection control practices. Now, the level of education is different. For the infection control team, they should be apprised of the latest guidelines, and they should have good knowledge of the basics at least. The healthcare workers who directly provide delivery of healthcare to the patients, that is doctors, nurses, have to be, their level of education has to be at the topmost. And other personnel, be it management, be it physiotherapists, dietitians, who give auxiliary care to patients also should be appraised at least of basics. So once you have trained, the next step, so every slide in this I am going to keep saying, you have implemented something, have something to monitor, have an audit process of it to see if you are on the right path. You have an endpoint, but you have already set path, but you should see if you are going in the right path or if you have deviated. So we have to have audit and monitoring system to guide us if we are on the right path. So, and the most important part of infection control program is the surveillance. So what does surveillance do? It helps us understand the infection pattern in our hospital, the resistance, and the other interconnected departments which will help us track the infections. So what we have to do is first surveil, then collect the data. So every month you have to collect data on all your medical devices and various other interventions, collect the data and find out if there is a trend which needs to be corrected, which needs intervention. If you have started the intervention, again go back to see if your intervention is working or not. So these are some of the surveillances that is expected every month. One is, as I said, infection. You have to track all the devices that have been which is used in your hospital, be it in the ICU or in the wards, and track their how they have they been inserted, have they been is it the right time to remove it, are there signs of infection. So all you have to track that to figure out whether there is a hospital, what is the trend of your hospital acquired infection, so that you can make your interventions as per the need. Next is to identify the most prevalent resistance pattern, so that you know what is your your local biogram. Identification of high risk patients, be it chemotherapy patients, neutropenic patients or transplant patients, you have to identify them separately and give special care so that they can be protected from, they are at a higher risk of developing infection, so you have to take special care so that they don't get infected. Next is existence and so as I said, infection control comes with a lot of infrastructural changes, so that has to be surveilled. Early detection of any outbreaks in your ICUs or any infection that is breaking out in your ICUs, only the daily surveillance will help you figure that out. And as I said, interventions, you have started an intervention, you need to have a system of finding out if your intervention is working or not. Okay, these are some of the multimodal strategies. So just teaching them or telling them, giving or distributing the guidelines is not how it will work. As I said, the behavioral change comes with a multinodal approach. So for that, the system change. So in fact, at anything you start, it has to come from the top. So your senior management, your administrative management should be with you, so that they give you adequate infrastructure and supplies to run an infection control program. So you should know your requirements so that you can convince your senior management as to what you require out of them. Next is education and training, as I said, and continuous monitoring of the process and feedback. Just having a classroom talk once and leaving is not going to be the end of it. You need to have someone who will give you a daily reminder, who will keep apprising you of what you have to do. So for that, you need a dedicated team who will help you on a daily basis. Culture change, as I said, only when you accept that you're going to do this and take it up as a part of your change will the change happen. One of the other multimodal approach is having bundles. So bundles are a set of tools which are programmed so that you can avoid infection due to particular devices. So in the coming talks, we will be covering bundles as a very good approach to preventing infections. As I said, monitoring, audit and feedback. Whatever you have started today something, you have to also make a audit checklist and a feedback to see where you are. So always, once you have done an audit, you have to share it with the end user whom you have audited. You have audited a ward, you have to tell them what is the finding so that they will make the changes which is required. and also to the, that is the individual change, and also to the hospital management, so that they are appraised of what is the problem and what are the resource changes that we need. So this has to be a continuous process. It has to be on a timely, it has to be done in a timely manner. The component 7 is having a workload, having a consistency in workload, staffing and bed occupancy. So having a hospital of a certain number, you know, you have to ensure that, you know, most of the beds are at a certain space. You have to ensure that, you know, they don't, you know, transmit infection between each other. So the bed occupancy should always be consistent. Just because you have more patients, I have to admit, you cannot put one bed between the bed. Those practices should not be a part of infection control at all. You're breaching everybody's safety in that. So the occupancy should not exceed the hospital capacity. At the same time, having this many number of patients also requires you to have that many number of healthcare workers to you know, cater to them. Having a proper nursing ratio is very important. Otherwise, if you have a ratio where the nurses are overburdened, they wouldn't want to follow, you know, they will be overburdened, frustrated, and they wouldn't be in a mindset to, you know, follow any of the instructions that we try to give. So from the infection control program point of view, we have to ensure that the distribution of the work is such a way that they will perform all their duties correctly. This is another important part of infection control, and this is the last component. So as I said, infection control comes at a cost. Okay, so that means that you have to have infrastructures and, you know, all the supplies. So patient care activities should always be in a clean and hygienic environment, and that ensure. So some of these are very, very basics. Having clean water, okay, from a good source, making water available for drinking, hand washing, you know, equipment cleaning. You have to ensure that your water supply is good and adequate. Access to hand hygiene, one of the most basic infection control practices. You have to make sure that you have facilities with hand rubs. See, you have an activity going on here, you cannot keep the, you know, hand rub somewhere, you know, very far away from it. You have to make sure that it is at access points, strategic access points, so that once something is done, they have immediate access to hand rubs. Wherever necessary, soap and water for hand washing. Sanitation, again, one of the very basic necessities of life itself. So in the hospital, you have to ensure that there is a clean sanitary facilities, clean environment, basic clean environment, whether it is in the ward or, you know, in the OPD or in your ICU or in the OT, giving a basic clean environment which is sterile is equally important. Now, waste segregation, providing separate bins for segregating waste, having a sharp container, puncture-proof sharp container, making sure they are segregated at the end and they go for correct treatment. There's no point we segregating it properly and, you know, we don't send it to correct places where it gets, you know, disposed of correctly. So it should be sent to authorized centers so that they do not cause any environmental pollution. Having a CSSD, for your sterilization of most important equipments to do most of your surgical, this one should be part of the team. So, you know, it is not an option. These are things that you have to run an infection control program. Having adequate number of positive or negative pressure isolation based on what is the requirement and what is the capacity of your hospital. But see, the whole process is about preventing infection. So when you have you need strong isolation facilities in your hospital so that all the you know, resistant bug patients can be isolated safely from the others who have not had an infection. So having a strong isolation facility is equally important. Ventilation system, be it in the OT or be it in the ICU, having a good ventilation system is also important. adequate disposal of risk. I have this one, risk assessment system. So, see, when you have a hospital of this stature, you need to have facilities which will ensure that you are in a safe environment, be it electricals, be it water, be it sanitation. So, you need to have a strong facility department and maintenance which will cater to every day. It is an everyday process. Every day they have to check what is, where it is going wrong, and it has to be done on an everyday basis. If there is a renovation happening near any high risk areas, we have to ensure that we are looking after that. Be it high risk areas which include burns unit, chemotherapy units, OT, those are areas where if there is any renovation, you have to make sure that you are informed of it and you take care of this. So these are the 8 components which needs to be strengthened so that you can have, at least, as I said, this is not the end of it, but this is the basic. So if you have this, you can build on it, and this is like giving a strong foundation. Based on more than this, it's about how you build your department, how you make it, make your infection control program more and more. Thank you. Any questions?
If you have any questions, you can ask Dr. Divya if you have any. Thank you, Dr. Divya, for the wonderful talk. I would like to ask Uday sir to give a certificate of appreciation to Dr. Divya, to our one-woman army of infection control of Apollo Seshadripura. Going on to the next event, we have next topic will be spoken by Ms. Eva, Ms. Sharon and Ms. Selvi, who all are from the infection control team in Apollo Seshadripuram. Who's coming first? Eva sister will come first.
Up and down ಮಾಡೋದು ಹಿಂಗೆ ಸ್ಲೈಡ್ಸ್ ಸರ್ ಓಕೆ ಇದು ಓಕೆ Namaste all. I am Eva Sweetlin. I am infection control nurse. Today we are going to discuss about surgical site infection, which is easily grasped first to prevent surgical site infection prevention. There are 4 components we are going to discuss. One is regarding bundles and its definition, pre-operative phase, operative phase and post-operative phase. So let us see bundles. What are bundles? Bundles are group of evidence-based care components and practices for a given disease. These bundles, when executed together, may result in better patient outcomes. These bundles, when followed, help to prevent healthcare associated infections, namely VAP, it is ventilator associated pneumonia, VAE, it is ventilator associated events, CRBSI, central line related bloodstream infection, COTI, catheter associated urinary tract infection, and SSI, it is surgical site infection. So we are going to discuss about surgical site infection. What is surgical site infection? A surgical site infection is an infection that occurs after surgery in the part of body where the surgery took place. SSIs are classified into incisional SSI, it is superficial. Example, suture area infection like that. Deep or organ space SSI, which affect the rest of the body other than the body wall layers. These superficial incisional SSI, it affects skin and subcutaneous tissue. The deep incisional SSI affects deep soft tissue, and organ or space SSI affects organ and space. So, we are going to see preoperative space. What are the things we are doing? So, we are screening for risk factors. That health we are screening. We are screening for risk factors and any infection like MRSA. And next is skin preparation. So, we perform chlorhexidine bath before surgery to elevate all harmful bacteria from the body. That is why we prefer to give preoperative bath with chlorhexidine. What is the solution we use is chlorhexidine, because it is a long lasting disinfectant, and also the residual effect is more. The residual means the long lasting effect is more in chlorhexidine. And we are using chlorhexidine solution for all the things. So, we come back to skin preparation. Okay. All operation patient, we are not removing the hair, but when it's needed, we use surgical clippers. We do not shave, because razors will give minute cut. The bacteria may penetrate through it. That's why we do not advise for razor saving. Avoid razor saving. The next treatment is antibiotic. Most of the cases they recommend pre-antibiotic for the cases to avoid surgical site infection. So, when we take antibiotic, it should be according to antibiotic prophylaxis. What are the cases? According to the case, the antibiotic is advised, how much dose and how many days we are giving. It should be according to the patient condition. So, next is normothermia. The patient should be febrile when we take for surgery, and the sugar level should be normal, or it should be under control. When the sugar levels are high, the post-op healing is delayed. That is why we insist on sugar. So, altogether we call as CAT decreases SSI. CAT means C for clippers, A for antibiotics, T for temperature, and S for sugar level. The Global Alliance for Infection in Surgery Bundles for the prevention of surgical site infection worldwide, it is shortly said as preoperative bathing or showering, surgical antibiotic prophylaxis, hair removal, surgical hand scrub preparation, skin antibiotic preparation. So, with us we are using preoperative checklist where all these things are done before sending to OT. Safe surgery checklist, where during surgery, before starting any surgery, this WHO safe surgery checklist has been done by our head nurse and doctor. So, we will move to operative phase. Operative phase, we should have clean and very well sterilized OT. So, we have clean and sterilized OT. And the second and foremost important in all the things is our hand hygiene. So, we have surgical hand wash, and each and every time we should do our hand wash, and it is 100% recommended in infection control. Safe OT practices, traffic control. We should avoid entering in the room on and off. So, you should have traffic control. Compliance with surgical attire. From the CSSD things till the wound closure, we should take care each and every step. Proper surgical scrub, we have 2% chlorhexidine for the skin preparation. Proper skin preparation with chlorhexidine based antiseptics, effective sterilization of instrument. In our hospital we use autoclave, ETO and plasma sterilization. We monitor everyday basis. Monitoring and preventive maintenance of hair handling system. We have FR filters in our OT and we monitor every week. We send culture and the report has been released and we check for the sensitive report. Safe OT practices continue. Adequate surgical prophylaxis we give 30 to 1 hour, 30 minutes to 1 hour before surgery we give antibiotic. Use of wound protectors to prevent tissue contamination. Careful handling of tissues by surgical staff. Disinfection of the environment during room turnovers and terminal cleaning. Safe medication handling procedures and safe storage of supplies. So after the procedure, what are the things we teach? So whenever they change the dressing, it should be under sterile technique. So whenever we are starting the patient, we should tell the patient that they have to take care of the wound. Any problem they have, any redness, any fever, anything they have to come to our hospital or they have to inform us. That's the education we give. And also we have brochures for wound care brochures that we give to the patient. And after a week, we call the patient and we ask the patient any problem they have. That's why we are having SSI tracking sheet. So every week and 1 month and 3 months, we call the patient and confirm whether they are in a safe position. Okay, if any problem they say, we will advise them to come to the hospital or we also will tell to the attending physician. So the learning objects. After this session, you will be able to develop an implementation plan for your surgical site infection prevention bundle. Identify and address local barriers to implementing your SSI prevention bundle. Use the barrier identification and mitigation tool. That's all. We will prevent all surgical site infection if you follow all the bundles. Thank you.
Next, we'll call upon Ms. Sharon to speak a few words on the infection control program further.
I'll stand here, Laura. Anna, slide எனக்கு கண்ணு தெரியாது சத்தியமா. Okay, this is the button, right? Namaste all, and here comes to central and associated bloodstream infection. This is so important when patient comes to the hospital with no lines and patient got an central and how to prevent. Anita. slide போங்க. When we see the introduction, the central line venous catheter, that is CVC, also called as a central line. Central venous line or central venous access catheter is a catheter placed into a large vein. It is a form of venous access. It's a large, long, thin, flexible tube used to give medication, fluid, nutrition, TPN, total parenteral nutrition, or blood products over a long period of time. This we use only for the ventilator patient for prolonged, when patient will not get any peripheral line. For that patient we use this CVP line. For epidemiology, CLABSI is serious infection that occurs when microbes enters the bloodstream through a central line. This is again, we have to perform a hand hygiene before we touch the central line, use a clean gloves so that we can prevent the infection. And CLABSI leads to a prolonged hospital stay and increases health care cost and the mortality rate. In 2001 to 2002, there's a 7% in increase of CLABSI, lost increases in ICUs, because in ICU we see more patients with the CVP lines, where in ICU itself they will insert the CVP line. While insertion also, there is a little protocol where we can prevent. In host factors, this 5 factors we have to see. First of all, clear chronic illness, that is CKD and malignancy, immune suppressed state, and total parenteral nutrition, loss of skin integrity or burns, prolonged hospitalization before line insertion. All this condition, if you see in your patients, be little more attentive and careful while handling the central line, because this condition of patients will get more infection. And what is a CLABSI? And it is a laboratory confirmed infection where a CVC is in place for more than 2 calendar days prior to a positive culture, and is also in place the day of or a day prior to a culture. If we see, for example, how CLABSI is, CVC placed in June 1st, patient febrile on June 4th, still patient is having a CVP line, and culture positive for Staphylococcus aureus in 2 sets, in the sense one is from CVP line and second one is from the peripheral line of blood culture, separates by more than 2 hours. We will consider as a CLABSI. And keystone bundle for interventions. Before insertion, what we have to do? And this is from, first of all, we focus on the hand hygiene, and secondly, maximal barrier precautions, where we have to wear a cap, gown, mask to prevent the infection, and drape the body full. And third is like skin preparation with chlorhexidine. After putting a chlorhexidine, and you have to wait till it get dried, and doctors has to insert. Give an incision. Scrub the hub, because after insertion we will withdraw the blood. That blood will be there in the tip. So scrub the hub for 15 seconds and put the cap. Optimal catheter site selection, avoid femoral site to get a cross contamination of infection. Daily review of lines, we'll see in the next slide. BSI bundle care, and we again focus on the hand hygiene. because when we rush, because we all are nurse, we know how busy it is, and when we go to the patient side, if you want to give any medication, please use the hand rub, at least to prevent if you're not using clean gloves. So first of all, we focus on the hand hygiene. And second is like use of transparent dressing. So in this transparent dressing, we can see if any infections are there, or else we can see if any oozing or any erythema. And scrub the hub. You have to again scrub the hub before giving any medicines. Okay, line flushing before and after procedure if no orders for medication. Then every 6th hourly or every shift. If there is no medication in the wards, if you shift the patient to the wards, if there is no medication, when you come to your patient side, flush it, and you flush every 6th hourly, or else if you have a time every shift. And dressing change every 5th to 7th day when partially out or soiled. If you see the patient, if you go to the patient side, when you see how is the dressing, if it is getting soaked, if it is partially out, but the tegaderm is coming out part, you can change the tegaderm to prevent a cross-contamination of infection. And this is what Apollo Seshadripuram is using the checklist, and this is the BSI bundles what we use here. And use of transparent dressing to be changed. This will use like morning, evening and night, all 3 shifts we does this, and our link nurses will help the concerned staff how to do this, and infection control nurse will come and cross check whether the staff has been done or not. And here comes again the height tracking sheet. In BSI we will monitor like temperature, site of infection in the catheter site, details of any blood cultures, and this will do every day basis, and previous one we will do every shift basis. And when we come to this in ICU, like every day we'll put the date and we'll write the date of incision and day 1, day 2 and day 3, and this is how we practice here. And we finally will see like parameters to be monitored: temperature, signs of infection at the catheter site, hypotension less than 90 mmHg, oliguria less than 20 ml per hour, details of any blood culture if sent. Total WBC count is more important. If there is no any fever, there is no any oliguria, or no any hypertension, only this WBC count will help us to see the infection rate. And take home message: hand hygiene, use aseptic precautions, follow bundle care approach. Thank you.
Sharon, for the very informative talk. Now Mrs. Selvi will come and speak a few words and further on the same topic.
Namaste all. So today's topic is all about the bundle care approach to prevent device related infection. It's all about CAUTI, catheter associated urinary tract infection. So the impact of CAUTI is, it is one of the 5th most common type of healthcare associated infection with an estimated 62,700 UTIs in the hospitals. So if you take into account some of the most common type of healthcare associated infection, that is approximately more than 30% of HAS has been reported. So estimated more than 5,60,000 nosocomial UTIs annually. So increased morbidity and mortality. The estimation is all about 13,000 attributable deaths annually. leading cause of secondary BSI with 10% mortality. So the excess length of stay is 2 to 4 days, increased cost $0.4 to 0.5 billion per year nationally, and we have unnecessary antimicrobial use. So what are the components of catheter insertion and maintenance bundle? So certain strategies help us how to prevent the COTI. Use a standard indwelling urinary catheters kit, standard which has got ensuring a proper insertion technique and maintaining a catheter according to the evidence-based guidelines. So how are we going to ensure the insertion technique? So it is all about aseptic insertion, which is recommended. Many nurses and other clinicians have to relearn proper techniques. So working environment does not resemble learning environment. Inserting clinicians should receive a competency-based training and be able to demonstrate indwelling catheter insertion competencies. So the practices should be observed and monitored in the real world setting after the initial training. So what are the essential aseptic techniques what we are following? So it is all about performing hand hygiene immediately before and after insertion, use of appropriate antiseptic or a sterile solution, perform hand hygiene after periurethral cleaning and prior to insertion, setting up a sterile field, sterile gloves, drapes, using of appropriate antiseptic single-use packet of lubricant jelly for the catheter tip. This is one of the most important things to prevent COTI. Securing the device, keep collection bag below the bladder level. If the catheter is accidentally contaminated, discard it immediately and obtain a new sterile catheter kit. So these are the strategies very, very important to prevent COTI. So following hand hygiene and glove use, perform hand hygiene before and every patient contact and before any manipulation of catheter device or site. These are the strategies we need to follow. Education related to specific aspects of urinary catheter care and frequent audit and feedback. So how are we maintaining a closed system? If there is a break in the aseptic technique, disconnection or leakage occur, replace the catheter using aseptic technique and a sterile equipment. Consider using urinary catheters with pre-connected sealed catheter tubing junctions. So we have another unobstructed urine flow. Again, this is one of the leading cause for COTI. Maintain a bag below the level of the bladder. Ensure the bag is emptied prior to the transports. So we nurses tend to shift a patient to a different units. Never bother. The bag is full. It has to be emptied before we transport the patient to a particular department. Use a catheter securement device to anchor the catheter. Keep the urine bag off the floor to prevent infection. So comes to the catheter care, the meatal cleaning, soap and water is the best solution. Perform peri and catheter care per facility policy. Assess the patient for any pain or discomfort. Inspect the meatus for any redness or irritation and drainage. Assess the catheter where it enters the meatus for encrusted material and the drainage. Clean the meatus during daily bathing. Do not clean with antiseptics. Remove any uncrusted materials on the tubings. Ensure the tubing does not go in out of the urethra during cleaning. So the take-home points to prevent COTI: consider the use of checklist. Explore how the unit culture affects your ability to insert and maintain indwelling urinary catheter according to the evidence-based guidelines. If the patient must have an indwelling urinary catheter, pay attention to maintenance practices. It is not complicated, simple. That can be better by using soap and water for the periurethral care. So this is the COTI bundle checklist. So we need to perform hand hygiene before and after procedure, meatal cleaning with the soap and water, collection bag placed below the waist level, urine emptied at the regular interval using separate container. So the urinary catheter has been continuously connected, avoiding loops. Thank you.
Thank you very much, Selvi, for the informative talk. The audience, do you have any questions to ask all of the three ladies? Or any questions anybody wants to ask?
Any questions? For all the patients you'll be doing, for only for the implants or major cases you'll be doing?
It is recommended that you do for all the patients.
All the cases, even the simple cases also, like, okay, thank you. No, not shaving, not shaving. Clippers only. Yeah.
Shaving causes microaggression, which can become a portal of entry for the microorganisms. So whenever, if there is no requirement for a skin preparation, the preparation with removal of the hair, please don't do it. If it is necessary, make sure that you use clippers. Yeah.
Ma'am, I have a question. What about the BMI role? How is the BMI playing a significant role in SSI, in prevention of SSI?
So the larger the EMI, it influences wound healing. It is associated with more comorbidities, okay? And you have to ensure that the antibiotic given prior to the surgery, perioperative prophylaxis, is dose adjusted, okay? So having a BMI is actually one of the risk factors for developing a wound infection. So you have to take that extra care to make sure that, all the bundle checklists are taken care of. Okay.
So do you suggest in a double dose of antibiotic if the surgery is prolonged?
Oh, so irrespective of the BMI, if it's a prolonged surgery, you have to make sure that intraoperatively you dose it again. Okay? BMI, it determines BMI will tell you what is the dosage. Irrespective of you're repeating the dose or not, it has to be weight calculated. Yeah?
Anyone from this side?
Ma'am, is there any significance of maintaining a good air window for maintaining or for prevention of SSI?
Air window, I don't understand. What is air window?
HEPA filters, ma'am.
HEPA filter. Yeah. That is one of the major requirement for an OT in an operation theatre. Okay. So basically HEPA filter maintains a unidirectional flow of the air. So that's a definite requirement inside the OT, not otherwise. Inside OT, yes, it's a requirement.
Here? Anyone?
Can we?
Okay, yeah. Okay, so Dr. Saravanan, please hand over a small token of appreciation to Eva. Dr. Prasad, would you please come and give another token of appreciation to Sharon? Dr. Abul, hand over a small token of appreciation to Selvi sister. Thank you all. And now moving forward for the next topic. We have Ms. Shashikala, who is the head of nursing, who will speak a few words. Prior to that, Dr. Divya will want to have a small introduction to her.
So what WHO recommends is that you have an infection control nurse every 250 beds, okay? But if you look at a modern preventionist, the work is just you know, it seems to be becoming worse and worse considering the kind of patients we have, kind of patients we cater to. Having one single infection control nurse will just compromise on the quality. You just have one person who cannot overlook every patient. You have a big chemotherapy unit, you have a big burns unit, and a big ICU. Literally, your infection control nurse is stuck there. Okay? So, even WHO has not revised it, but they are recommending more infection control nurses in your unit. But we have come up with a unique concept of having link nurses. So link nurses are one champion in your own ward. It's like having a mini infection control nurse in your unit so that it makes the process go seamlessly in your particular area. So infection control nurse basically cannot be everywhere, right? So you have subunits where you have one nurse taking care of it and reporting to the infection control nurse. So that is something that we are experimenting on. And I have Mrs. Shashikala, who is our head of nursing, and she is in charge of it, and she's doing a fine job with it.
Thank you. Good morning. Namaste, everyone. She has already introduced me. My name is Shashikala, Nursing Superintendent, Apollo Hospital, Sheshadripuram. A warm welcome to you all for our infection control conference. So I'm going to talk about today role of an infection control nurse linking to our patient care in minimizing the infection. So as you all know, as you all know, infection control is a crucial healthcare setting to prevent the spread of infections. The infection control link nurse plays a vital role in promoting and maintaining infection control practices. So she has the duty to help create and maintain an environment to ensure that all the patients are safe, patient visitors are safe, and the healthcare people are safe enough. And this will be fulfilled by using their infection control knowledge and nursing and teaching skills and their communication skills, and most importantly, attitude and appropriate to the situation. Who is an infection control? Lot of introduction already was happened. An infection control link nurse is a designated healthcare professional responsible for coordinating and implementing infection control measures within the healthcare facility. They act as a liaison between healthcare staff and infection control team. They act as a role model, and they act as a change agent to support all the healthcare facility staffs. So what is the criteria? Because NABH 5th edition has come up with every hospital should have an infection control link nurse to provide an appropriate care to the patient and to get a better outcome. So as a requirement, one infection control nurse cannot be there everywhere. Since many specialization, many different units will be there, and they 24/7, there should be visualization, there should be a supervision. So if we create a link nurse in each department, so they will make sure that whether the practices are happening properly. So they must be, how are we selecting? Just like that we can't just show, okay, you come, you do this, and this is what you will have to do. Just like that we can't be advising them. So we have to see that whether they are interested to learn and practice, and they should be energetic and active in their daily work. They should know their responsibility, and they should have at least 2 years of clinical experience. Unless until you have an experience, you don't know the ground level reality. So I don't think they will be able to correct them, and they will be able to guide them properly. And they usually work in particular specialty areas and clinical wards, and they will help ICN, infection control nurse. So they need not be relieved from the duties. They, along with their work, so they can perform in even ICU wards along with their allocation. This is an additional responsibility. Whoever is eager to learn, we have to give them the opportunity and make them to do work as infection control link nurse. The success of this scheme highlighted the importance of involving clinical staff in the implementation of infection control activities. So many studies have shown that when we are promoting from each department, identifying them, teaching them what to be done. So there were better outcome from the patient. So patient have recovered without having any infection. There were many studies have shown after that only the NABH came up with this an idea to have an infection control in all the departments. So how do we prepare them? There should be they should be usually recognized by the colleagues, whether any of your department staffs are interested to do this link nurse role. And educational components of link nurse system should be developed locally based on the local need of the hospital. Depends on your bed category, 150 or 50 or even 250 bedded. Depends on your bed category. What kind of infection control practices we have to allot to them. So we have to create a module. After creating a module, we have to schedule for a training. Training protocol as per the schedule. The infection control, main infection control link nurse have to take and initiate to train them day by day, daily. So with the particular SOPs on infection control procedures, protocols. After the training of infection control nurse, specific tasks and roles as required have to be clearly mentioned to them. And they should be an activate. We have to make them clear, that make them understand that they are acting as advocates, not the spies of their colleagues. Even if they tell them to correct this, people should not be taken in a wrong way. And role of a link nurse to lies between their clinical area and infection control team. They are bridging a bond and they are linking to our management, infection control nurse and the infection control protocols and practices. Help in all the implementation of infection control policies, to take responsibility with regards to application of infection control policies and procedures within the clinical areas, to coordinate the required activities with the nurse in charge of clinical areas, and they will have to coordinate with the infection control team for any lack of precautions, and to be organizing officer in there. She should be an organizing officer in their clinical area if patient needs an isolation, and she should come in front and coordinate with them to shift the patients wherever it is required, to attend the regular infection control link nurse meeting and form a network within the hospital. That means after the selection of criteria, we have to make them to attend and some of the few basic questionnaires. After the questionnaires, we will get to know their knowledge. Even though if they are interested, if they are poor in knowledge, we can train them. But some point of time, we will have to just recheck with them whether they have improved. And we should have a regular meeting with the infection control nurse, whether they have improved, is there any deviation found, whether any help required from the management or infection control team. So responsibilities, when it comes to responsibilities of infection control, what exactly she is supposed to do? So as it was mentioned already, she should be having educating skills, good communicating skills. So conducting educational sessions on infection control practices for healthcare staff in particular area, keeping staffs updated on current guidelines and best practices, training new employees on infection control protocols. So surveillance and monitoring, conducting regular surveillance of hospital acquired infection within the facility, collecting data, analyzing the trends and identifying the areas of concern along with the infection control nurse, reporting to the IC team about all data whatever she does, isolating relevant infectious diseased patients, monitoring biomedical waste within their area. How are we monitoring? Already we have taught the people how to segregate which waste will go to which color bin, whether they are practicing at the bedside, whether they are transporting properly, whether they are discarding properly. All these things being in the department along with allocation of the patient, you will have to just observe. This is as a routine. So we should not be thinking that that is an extra burden for them. Why should we do it? It is in our job, whatever we do. Just we have to have a clear observation whether we are and our colleagues, our staffs are practicing properly. Policy development, assisting in the development of revision of infection control policies and protocols, ensuring policies align with the current guidelines and regulatory requirements. If you find something which is not related to the policy which we are practicing, it has to be noticed to the infection control nurse. Outbreak management. Everyone knows, I think, what is outbreak. If any of two or more than 2 are patients, if they get an infection from the same organism in the same place at the same time, we consider that is an outbreak. Correct? So how to manage this outbreak? Collaborating with healthcare teams during outbreaks or infectious disease incidents, implementing control measures such as isolation protocols and cohorting. What is cohorting? Can anyone tell me what is cohorting?
Same organism patient will be keeping in the cohort area, like COVID positive.
Very good, very good, yes. If they have infected with the same organism, we will be keeping the patient in a same room if the single room or isolation separate rooms are not available. If we have in our facility, if single rooms are available, preferably we have to keep them in a single room. If not available, this decision can be taken after discussing with our ID doctor. And tracking and monitoring the progress of outbreak management strategies. Equipment and environmental management. Evaluating infection control practice related to ventilation. Ventilation, somebody spoke already about HEPA filter, air exchange, whether it is the particular, as per the guidelines, are we doing it? HEPA filters are frequently changed, whether maintenance people are going and checking. So, and the water quality, frequent culture and sensitivity, whether whatever we are using for even hand washing, whether the water is pure enough, and waste management, as I have already mentioned. So all these things we have to observe as a link nurse. Ensure proper cleaning, disinfection, sterilization of medical equipment. Can anyone tell me that cleaning, differentiation between cleaning, disinfection, sterilization? Yeah.
Cleaning does not remove the spores, whereas in disinfection the spores are also. I mean, in disinfection it is just cleaning, which includes with killing the microbe, whereas in the sterilization there are spores.
Very good, very good. Yes. So cleaning, it means just killing the, removing the dirt. In disinfection is killing the bacteria and viruses, and sterilization is killing the bacteria, microorganisms, and as well as spores. And overseeing the maintenance of clean and safe environment, whether the people have used. Anyway, I am going to explain in upcoming slides. And one more is collaboration is very much required, and the communication. Serving as a point of contact. The link nurse is serving as a point of contact for infection control related queries from staff and the management, collaborating with other departments to implement infection control measures. So activities to be focused. What all main activities we are supposed to focus on? Hand hygiene monitoring. There are many ways of hand hygiene practicing. How are we monitoring? Correct? One is direct observation, by seeing whether they are practicing the proper hand hygiene practice, whether all the steps are followed, whether all the movements she is following or he is following. Correct? By direct observation and correcting them if they are not practicing properly. And another one is CCTV surveillance. Also we see through CCTV whether they are, because many people we have the habit of, if nobody is observing, we do however we want, right? So we can even do that, the surveillance audit. And also by counting our product. So most of the times we don't think of how should we observe, correct? So by counting the solution, the product which we use for hand washing. So what is the consumption, number of consumption? By seeing that, we will get to know whether they have used hand washing, whether they have done the hand washing practice or not. And device days collection. Device day collection, it may be a IV peripheral line, as guideline 3 to 4 days, maybe catheter up to 7 days, more than 7 days if it is continuing, what is the reason? and what is the justification of continuing the catheters and other lines, whether patient is stable, where unstable, whether this has to be continued, whether to be continued if patient is stable, why are we continuing. So you are empowered to inform the consultant or infection control nurse or the ID doctor, maybe this patient may not require, you can take a call. So let them have a discussion with the consultant and they can remove. So you are empowered as a link nurse to discuss all these things with your head infection control nurse. Segregation and isolation of infected patients. By assessing the patient, you will get to know whether this patient is normal, because many patients you have seen in your life. And if there is any kind of a changes, you will be able to identify. Correct? So when you identify, so when you notice, you just intimate to the team, infection control team. So somewhere I am feeling that this patient is not absolutely normal. So can we just go in depth in this case, whether this patient is required to shift to somewhere, whether this patient is safe to keep with another patient. All these thoughts and thinking the infection control nurse should have practice. Follow up of room terminal cleanliness, whether all the rooms surface cleaning is properly done, whether the solution, proper solution, approved solution, detergent, whatever is used, whether the dilution was proper. Because many of us will not notice how much the solution they have taken. They have just poured, because ounce glass will not be available, they will just how much ever, just like approximate, they will just pour it. Correct? So because guidelines were prepared, this much have to be added, then only we kill the microorganisms. If it is not followed, I don't think the cleaning will happen properly. All these things, I think as an infection control nurse, even this is even non-infection control, non-link nurse, also it is responsible for every job, every one of us job it is, but still the infection control link nurse have to observe all these things. And if any suggestions and support to IC team is required, can be given to them, and help in family education. Family education. So you can do many things in giving family education related to their health, post of wound care, hand hygiene, food habits, social and isolation precautions. So many things, if you are trying to give them the education, you just make them understand. And where and why do we fail to practice all these things? One is poor and lack of interest. Unless until we have an interest, even though you know how to do, but when you don't have an interest, you don't want to do, you will not be doing it. And lack of support from the team and seniors. Staff turnover, many staffs coming and just going, and many staffs will be practicing in a different ways, and shortage of staffs. After duty, especially on night duty, post night duty, you are already exhausted and you may fail to practice the proper infection control protocol. The conclusion is the role of infection control link nurse is still evolving. A single infection control nurse cannot manage all the wards consistently, hence infection control link nurse can maintain the uniformity of care everywhere in our hospital. Authorities should understand their role and support and appropriate their involvement for infection control implementation. Understanding their role and limitations is a key note to the success. Thank you so much.
Thank you, Shashikala, for the talk. Now, any questions from the audience part on this topic?
Hello.
Arun has one. Arun has one question.
Yeah. One of my colleague, my name Dr. Afan Sami from Fortis Escort Hospital, he has asked a question saying that is there any guidelines or reference for ratio of allied department like number of quality personnel, quality nurse, ICN and nurse educator as per the number of beds?
Exact ratio I'm not sure about, but normally what I know, am I audible? Yeah, I think for 150 bedded.
So our hospital example I am going to take, as per the guidelines for 150 bedded hospital, we have to have one infection control nurse, one educator, one quality nurse, and also the link nurses in every department we have to have.
Thank you.
Any additional you wanted to add, Dr. Divya?
So 150, the intention of the link nurses is to reduce the number of infection control nurses. So instead of increasing the number of infection control nurses, we have increased the link nurses so that, you know, we have more work done.
Thank you, ma'am. Thank you. Any questions?
Any other? She has another question.
Ma'am, is it only one linked nurse from every department, or from like every shift one linked ICN? I mean,
Yes, we will be happy if we have each shift one link nurse.
but as per the protocol which you said, no ma'am, at least they should have 2
They
years. We
but
have
actually
upcoming.
as per the protocol, as per
Yeah.
the guidelines, in one department, one link nurse should be there. But more numbers if we have, well and good, and it will help a lot in preventing the infection. But as per the guidelines, as per the protocol, in each department, one link nurse must and should, we should have.
So that link nurse can be the in charges as well. It's
Yeah,
fine.
can be. Can
Thank
be.
you.
Thank you.
Any questions?
Okay, Dr. Divya, please hand over a certificate of appreciation to Shashikala. Thank you. I think we've had a good session so far, a first session. Short break for coffee, and then we reassemble after some time. Very short break, okay? By 11:30, we'll start the next set of quiz. And please register yourself for the quiz. There's a quiz competition later in the afternoon. So please register your names for that. thing? Like, I hope you have. Nobody was there. Otherwise, okay, once this talk is over. Okay, coming to the next thing, we have Dr. Spurti who will talk on the role of diagnostic stewardship in infection control. Dr. Spurti is our microbiologist. So please welcome Dr. Spurti.
And Lila. Yeah, I should hold this in hand. Okay. So welcome back to the second session on clinical stewardship. So has anyone of you heard on antimicrobial stewardship? What do you understand by antimicrobial stewardship? Okay, so I'm sure none of you would have heard about diagnostic stewardship. I'm sure. Did you? So I'll make you understand what is AMS in simple words. It is an interprofessional effort across the continuum of the patient care that involves timely and optimal selection of dose and duration of an antibiotic for the best clinical outcome for the treatment and prevention of infection with minimal toxicity to the patient and minimal impact on the resistance and antibiotic-induced adverse events. So what does it mean in simple words? It simply means treat the patient correctly. Use the right antibiotic in the right dose and at correct duration, at the proper route of administration. Use antibiotics whenever necessary, and when it's not necessary, stop the antibiotics. The other prevention of infection indication is for pre-surgical prophylaxis. So in simple words, use of the right antimicrobial for the right patient at the right time with the right dose, route and frequency, causing the least harm to the patient and future patients. Why future patients? How does treatment of one patient affect the other patients? It is because of the curbing of the bug. If we properly handle a patient who is having an infection or XDR infection and take all precautions so that it doesn't spread to the next person, we will be curbing the bug there. We will not allow it to spread, and also will reserve the drug. What is diagnostic stewardship? The World Health Organization defines it as coordinated guidance and interventions to improve the appropriate use of microbiological diagnostics in order to guide the therapeutic decision. So there are two factors in a diagnostic stewardship. One is the clinical component, other is the microbiological component. So all of you agree your lab reports affect your treatment to the maximum extent. So would you agree the lab report should be correct? Yeah. So would you agree right sample has to be sent? So that is what is diagnostic stewardship about, okay? In clinical component, it involves where actually the clinicians are involved, ordering the right test, collecting the right specimen, okay? I will be elaborating on this in future. Coming to microbiology components, performing the test by right method. This is the laboratory part, reporting the results in the right way and communicating the report at the right time. What if the report is ready but you haven't released it for another 2 days? Will it benefit the patient? So we are all healthcare workers and we should work for the better of the patient care. Coming to indication for ordering the right test, right patient. Suppose a patient is having a wound swab and a localized infection. Would you recommend blood culture for the patient? Yeah. So you can go for the secretions, exudate culture, that's enough. And suppose a patient is having, this is a rainy season, and it is more season for diarrhea. Would you go for a throat swab culture or some respiratory secretion culture? No, you would look for typhoid, cholera, and other diseases which are prevalent in that particular season. So the clinician has to select the patient. He has to arrive at the presumptive diagnosis based on the patient clinical history and examination findings, and order the right test. He should narrow down to the selection of the test. And coming to selection of the test, suppose there is a suspected case of typhoid, and it is the first week of illness, and he recommends stool culture. Is it correct? Yeah, because first week of illness, the bacteria is present in the blood. So you should order for blood test. Stool cultures start coming positive only in the second week. In first week, if he orders a Vidal test, is it correct? Because Vidal comes positive only after first week, and it may lead to misdiagnosis. Means we will give a negative report. Lab doesn't know what the patient is suffering from. Obviously, the lab won't come out and examine the patient, and it would be negative, and you will rule out typhoid, and you will treat for something else instead of looking for typhoid. So right patient, right test, and right time is very important. And collecting the right specimen, I'll elaborate about it in future. Coming to the microbiology part, writing the test, sending the specimen doesn't end there. We have to be, the laboratory personnel has a high responsibility of preparing their directory of services. We should make sure that the variety of tests are available for your choice, and whichever is needed in that particular area, in that particular time. We should make sure all the reagent quality is good, media quality is good. We should prefer automations over, I'm not telling conventional are not good, but automations has much more advantage than conventional techniques. I'll tell you about it in future. Implement molecular test if possible, if it's feasible. Look for biomarkers like procalcitonin or CRP, etc. Then rapid point of care test like latex. Can you name one of the latex tests which you recommend? Okay. Have you heard of CALAS for cryptococcal antigen? Okay. So you will probably, you don't know, it's okay. So after all this, we should ensure that the sample is processed correctly, the personnel is trained, the sample is interpreted correctly, and all of it. And right interpretation of the result. At every level, we should have a trained personnel to interpret every test in the correct form. It's not just the instrument printout. We have to analyze the instrument printout and give a analyzed report to the clinician. And last but not the least, communicating the result. If the report is ready and report is not given to the patient, then it's as good as not done. So communicating is very important. So to summarize, diagnostic stewardship is accurate presumptive diagnosis, appropriate sample collection. I'm sure all of you are having your own sample collection manuals, right? Yeah, and transport to the lab at the earliest. For example, sample is collected, the clinical team would do rounds at 10 a.m. They will decide to send for a procalcitonin test at 10 a.m. But sample is collected only at 12 a.m. There is a 2 hours of delay. And sample is further transported to the lab after 2 hours. And lab reports after 2 hours. And you see the report and act on the report after 2 hours. It's totally 8 hours. But this can be cut down if you ensure there is a proper transportation to the lab and maintain the transport temperature, because it will deteriorate the quality of the specimen. So what is turnaround time? For a lab, it is just from the sample received in the lab to the dispatch, release of the reports. But does it help the patient? Only lab. We have, irrespective of whatever time the doctor has asked the test, our sample is collected by the nurse in the ward. We do the test and release. Does only the lab that benefit the patient? what helps the patient? Overall AMS stat. See, there are 3 types of stat, okay. Coming to the broader spectrum, AMS stat. AMS stat is, that's what I told you, decision of ordering the test taken by the clinical team and till the action taken, okay, I'll tell you in a sequence. So first the clinical team decides to order a test, okay, say at one time. I told you 10 o'clock. Then specimen is collected at whatever time, say 12 o'clock. Then the ward sends the sample to the lab at say 2 o'clock. So what is the delay? 4 hours. Where was the sample lying? What was the storage temperature? Would you not take care of it? If not, the sample will deteriorate. Then after that, we do the test. It takes our own time and we release the report. And once the report is released, it will reach the clinical team. But it's not acted upon. Finally, the clinical team acts on the report. So AMS stat is the one which affects the patient to the greater extent, right from the time of decision of ordering the test to the action taken time. Overall, this is the one which affects the patient. So what are the ways to reduce the lab TAT? Is pre-analytical enough manpower and enough resources. See to that there is no shortage of resources anytime, and include few processes which have a better TAT. Specimen transport time has to be reduced by ensuring enough manpower and educating the staff about the importance of sending the sample early. And suppose you collect all the samples and send to lab only 4 hours once or 6 hours once, that frequency can be can be reduced to 1 hour or 2 hours once. Then pneumatic tubes will help a lot in reducing the need of manpower and reducing the specimen transport time. Report dispatch time can be improved by ensuring there is a software-based release of the reports. So what is hangover time? Hangover time is from the time the clinical team decides to order a test to the time actually sample is collected. And action taken time is once the report is available, the time taken by the clinical team to act on the report. So this is an example. So clinical team would do rounds at 10 a.m. It was a suspected case of sepsis. Patient was on vancomycin and meropenem. So it was done at 10 a.m. The decision was taken at 10 a.m. The clinical resident obtained the blood culture sample at 1 p.m. So what is the delay? What is the delay? 3 hours. So after that, the sample is collected. Within 1 hour, it is sent to the lab, and within 10 minutes, it is loaded into the blood culture system. And the blood culture system flagged positive at 8 p.m. So within 6 hours, the bottle has flagged positive. And within 20 minutes, we do the gram stain and we report it to the clinicians by another half an hour. So what was seen on the smear was a gram-negative bacilli. So do you all agree each bacteria has a different treatment? Gram-positive has a different treatment, gram-negative has a different treatment. So if you see this, vancomycin is there, meropenem is there. Vancomycin is a gram-positive drug, whereas meropenem is a broad-spectrum drug. So in this case, you know there is no GPC, and so the clinical team plan to stop vancomycin. So it is an antimicrobial stewardship intervention, stopping the drug wherever it is not necessary. Next, then the GNB grew and the report was ready after 2 days, and finally the isolate was found to be sensitive to all the drugs, including ceftriaxone and other cephalosporins. But meropenem was there. Meropenem is a higher end antibiotic. So now the spectrum can be narrowed down to ceftriaxone, and the clinical team did it. So this is how the report helps the modification of the treatment, stopping unnecessary drug and starting the right drug. So, role of appropriate sample collection. Site of sample collection is very important. Suppose it's a wound, there is no point if you just scrape the wound from the superficial tissues. You have to debride all the superficial layer and collect the deep sample. And for blood culture, a femoral vein is a very known sample, like known area to get skin contaminants. So site of sample collection is important in that way. Standard aseptic precaution should be followed, because unless if you don't follow asepsis, it will lead to false positive culture reports, which may in turn affect AMS. AMS is antimicrobial stewardship. The time of collection, for example, for a TB specimen, what do you prefer? Like what time do you prefer to collect sputum sample? Early morning, yeah. If there is a sepsis case, I mean, when do you prefer to take a blood culture sample? Before antibiotics, and preferably if there is fever, just at the beginning of the fever, collect the sample, because after that it may be neutralized. So it is very important. It has a direct impact on the positivity of the culture reports. Then quantity of the specimen. Yeah, coming to time of collection, suppose the patient is undergoing a surgery and there is an abscess collected somewhere. An intra-op sample would be much specific than collecting in the ward. Then coming to the quantity of specimen. Have you heard of rejection of blood cultures? Yes. Why do they reject? Okay. Have you heard of asking a repeat urine sample? Okay. So you are aware of all of it. Very good. Then you have to label the container specifically so that there is no interchange of the samples and interchange of the reports. Now coming to role of direct microscopy. These are the few tests we do: gram stain, Zn stain, fungal stain, IIP, Albert's, hanging drop, etc. The importance of gram stain is it will help us to narrow down the selection of antibiotics, whether to include gram positive or gram negative. Zn stain, whether to start ATT or not. Then fungal stains, you know, septate filaments has a separate treatment. Aseptate filamentous fungus has a separate treatment. Engineering preparation is done for Cryptococcus in CSF. If it is positive, the specific antifungal has to be started. So likewise, if we release a direct microscopy result or communicate it to the clinicians as early as possible, it would guide them for the empirical therapy. It will help to the further course of microbiology workup. Suppose a smear is there and lot of fungal filaments are seen in the smear of the gram stain. So would you recommend the clinical team to register for a fungal culture? Yes, fungus is seen in the gram stain as well. So it will help in the further course of microbiology workup and interpretation of the culture reports. Suppose there are plenty of pustules in the microscope and organisms are seen and no growth. There is a little correlation, probably it will be too much for you, but we always correlate a direct microscopy report with a culture report. What is seen is grown or not, what is not seen is grown. So we correlate all that and release the reports. And critical call-outs are very important. So do you follow any critical call-out techniques in your hospital? What information do you receive? Huh? Yeah, any abnormal value like in microbiology it is positive CSF, like CSF in which organisms are seen, positive blood cultures, positive engineering preparation, and etc. So this is the laboratory, purely a laboratory part. We have to treat the specimen like a patient. Don't see a specimen as a specimen. That is the window for us to see what is going on in the patient. So implement correct methodologies, see to that it is processed on time, see to that it is interpreted in the right way and communicated to the clinical team so that it is beneficial for them to make use of it in the treatment. What is the role of accurate microbiological identification? See, each microorganism differ in their behavior. Each one differ in their behavior. So even we have guidelines to interpret when is it sensitive, when it is resistant and all. So it is CLSA guidelines or UCAST guidelines. So to know that which guideline has to be applied for that. Accurate identification is very important. Suppose a salmonella is identified as E. coli, will it not mislead your diagnosis? Yes. So accurate identification is very important in releasing a proper report and starting a right treatment. And how do you identify or perform antimicrobial susceptibility testing is by conventional methods and automated methods. I think now you have a lot of instruments like Vitek, which gives you minimum inhibitory concentration. This is another workflow where there is an interference by a rapid technology which has a better TAT compared to the conventional technology. It is all the same what I described earlier, but here the blood culture flagged positive and it showed GNB. And we did BioFire. BioFire is a type of molecular test. We have BioFire here. Many other setups will have many other equipments. So BioFire was done, and this BioFire detects the organism name as well as the antimicrobial resistant gene if present. So a BioFire report, we knew that the organism is E. coli and it was a sensitive strain, and we started on the right antibiotic much earlier. We need not wait for 2 days. Right on the day 1, we could start the right antibiotic. So accurate interpretation of AST is very important. If we give sensitive as resistant, resistant and sensitive, it would lead to disasters in the treatment management. So we follow CLSI and UCAST guidelines. How does the CLSI or UCAST guidelines set when to give sensitive, when to give resistant to the particular organisms? It is based on the microbiology characteristics of that particular bacteria, PKPD parameters of the patient, and clinical outcome data. So a bug can develop resistance either through intrinsic resistance or acquired resistance. I think our clinician would be speaking about this in detail in the next session. These are few resistant mechanisms. So a report should have the demographic details of the patient and sample tested, method tested, what is the growth status, antibiotic report. And when we release the report, I'll tell you about the cascade reporting. So this is a cascade reporting where one of the sample has grown Klebsiella pneumoniae. We have to segregate the drugs into first line, second line and third line. In fact, the first line only has to be reported. The second line and the restricted line has to be not released and released only on request. We just have to give these options for the clinicians for the treatment so that we reserve the higher antibiotics to handle a complicated situation. Okay. Coming to interpretation of a culture report, you must have come across so many antibiotics susceptible, resistant, in the brackets some numbers, telling that it is minimum inhibitory concentrations. What do you understand by minimum inhibitory concentrations? See, it is the lowest concentration of the drug which can inhibit the growth of the bacteria. How do you choose? Suppose there are 10 drugs and all are sensitive, or few are resistant and few are sensitive. How do you choose the right antibiotic? If we plot it in this, I hope I can include this in the report format in the coming days. This is the CLSI breakpoint which says sensitive, intermediate and resistance. The farther it is from the central line, it is the more effective antibiotic. That is how we have to choose. Lower the number, better the efficacy of the drug. In fact, there are many other factors which will help us choose the antibiotic, which will be covered by Dr. Divya in the coming sessions. Coming to, you must have heard about this terminology, multi-drug resistance means it is resistant to at least one agent of more than or equal to 3 classes of antibiotic. XDR, it's resistant to everything except 2 classes of antibiotic. PDR, it is resistant to all possible antibiotics available. So, it is very important to give comments or advisory services in a report. If you come across, please go through the comments and understand what the laboratory personnel is trying to communicate through the comments. I'll show you one example where a urine culture grew Acetobacter frundi and Pseudomonas aeruginosa. I have mentioned it as XDR isolate. Whenever you isolate an XDR patient, would you isolate them as infection control nurse? Yes. So this report helps you. It is an alarm for you to isolate the patient. Suppose there is some particular features of particular organism, that particular notes included in the report will help the clinician to choose the drug for the treatment. And this report is regarding the sample collection, where the sample was collected from arterial lines itself, both the samples for blood culture. And after certain days, it's very common that the arterial lines get colonized by the normal flora. So we asked for a fresh sample, and a fresh sample came, and the same was mentioned in the report. So take-home messages: accurate presumptive diagnosis helps in the proper choice of drugs and start proper empirical therapy. Clinical and diagnostic interventions taken to minimize STAT would help the patient to the maximum. Accuracy of the lab tests and reports helps in the antimicrobial stewardship. Thank you.
Thank you, Dr. Spurti. Any questions from the audience on this?
I'm sure no one will have any questions.
Okay. Moving forward to the next topic. And I would like Dr. Divya to give a small token of appreciation to Dr. Spurti. Next up, we have Dr. Himal, our intensivist, who will be speaking on impact of antimicrobial resistance. So, Dr. Himal.
Hello, can you hear me? Yeah. Okay. Want to switch off the light? Yeah. Good afternoon, I'm Dr. Himal Dev. I'm an intensive care specialist here. I congratulate the infectious disease infection control team on this wonderful program. And I'm also very happy to see so many people gathered around here for this important program. See, this is a very important program, not only for the doctors and the nurses as well as the paramedical staff. Why should we listen about antibiotic? Why should we listen about antibiotic microbial resistance? I'm going to tell you through the set of slides, and by the end of the slides you'll understand why it is so important that we're having this workshop and why everybody should be knowing what is antimicrobial resistance and what's the burden of the antimicrobial resistance and how are we going to tackle it. Can we switch off that light also? Okay, so I'm going to talk about impact on antimicrobial resistance on patient care. So before I start the the session, anybody knows who is this? I don't know whether anybody put it up before. Everybody should know this. If one, not Louis Pasteur, no. Somebody said I could hear. Alexander Fleming. So what did he do? So he's the one who discovered the miracle drug called as penicillin. And it was actually an accidental discovery. He found penicillin. It was discovered in 1928. In 1945, when the World War was happening, it was considered as miracle drug, and he received a Nobel Prize for that. But you know, he told at that time when he received the Nobel Prize, he discovered an antibiotic. Everybody thought infections are gone. You discovered an antibiotic penicillin, all the infections are gone. But at that time only he thought, and he bought this thing, saying that there can be a possibility of developing a resistance to this antibiotics in the future if you are not using it in the right way. Okay? This is what he said. It is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentration not sufficient to kill them. That means if you use lesser dose of antibiotics, these organisms are not killed. that same thing can happen in the body also. That means if you're not using the antibiotic in the right way, or if you abuse the antibiotics, you're going to develop the resistance to the organisms. The miraculous drug is no more a miracle. Okay? So if you look at this years, starting from 1920s, where he discovered the penicillin, up to 1980, so many antibiotics, can you see, have been discovered. But if you look at last few decades, 10 to 30 years, there is a very less number of antibiotics discovered. This is called as discovery void. We don't have much choice. This is the burden. Okay? This is what you have to realize, how difficult it is to find the antibiotics. And if I ask all of you, what is the number one global threat right now? Is it a ticking time bomb? Do you think it is a terrorism? Do you think it is a global warming, or do you think it is a natural disaster? What is the number one? Yes. So look at the statistics. In 2050, the superbugs are the ones which are going to kill more than cancer. See, this is the statistics. Among all these road traffic accidents, diabetes, cancer, more than that, the antimicrobial resistance is going to kill a lot of patients if you don't handle it in the right way. Okay? So again, if you look at these statistics, I'm going to show you a lot of pictures so that it will register in your mind why it is important. Why the nurses or any paramedical, I mean, I'm sure doctors will know it, but why you have to take it is because you are the one who is seeing the patient every day, you are the one who is looking at the antibiotics, and you have the right to advise the doctors and other people to optimally or judicially use the antibiotics. Okay, this is our, it's what you call, this is our, it has to be done from the nursing part. Okay, so if you look at this area, years, if you look at all the antibiotics from 1953 to 1968, this is the duration. It took so many years to develop the resistance to these antibiotics. But if you look at 2000, 2010, for these antibiotics, it has taken only 1 or 2 years. That means we are using so many antibiotics in a wrong way. It is just taking 2 years to 1 year to develop the resistance, whereas it took so many years to develop the resistance. Okay? These are the different resistance pattern. If you look, the most commonly used antibiotics right now will be, or abused antibiotic is carbapenem, that is meropenem. Okay? So if you look at the data, the carbapenem resistance for Acinetobacter is 78% in India, whereas for Pseudomonas it is around 30%, and for Klebsiella it is around 57%, and India 29%, which is very significant. That means these many percentage of patients are not responding to meropenem. So if you are starting a patient for meropenem, you have to think 10 times whether this organism is effective or not, whether should I continue this antibiotics. Unnecessarily you are starting an antibiotic which is not useful, and you are going to increase the resistance. Look at this data, very bad. No? This is India, this is US, just a comparison. It's in 2000 and this is in 2000. The grey one is 2000 and the blue one is 2010. Okay? How much antibiotic has been consumed? In 2000, the antibiotic consumption in India was around 6 standard units. 2010, it's so much. Look at the US. In fact, the antibiotic usage has gone down. Does it mean the infection has gone down in US? No, it's not. They are using the antibiotic in the right way. Okay, they're not abusing the antibiotics. And look at the sales of carbapenems. Look in India, Pakistan, and Egypt, look at the sales. Okay, over the years it has gone up. But when you compare to US, the sales is almost the same. Okay, so what we are doing wrong? There is something we must be doing wrong. So this has to be understood. So you all know this iceberg, the classical Titanic example. You only see the tip. We all say superbugs. What is superbugs? The organisms which are not responding to our antibiotics, which are developed resistance. So we see a superbug is there, but why it is there we have to see. So there are two possibilities. One is inevitable. So whatever you do, it is a natural thing. Anything is there, eventually it will get resistance. Okay? But that is not preventable. That is not that much. But there's a huge part underneath the sea, this part which we can actually prevent and change. What are these? These are the weak points. Weak surveillance and regulatory systems. The surveillance is not very good. Inappropriate use of antibiotics, which causes selection and multiplication of resistance antibiotics. Self-medication, taking our own antibiotics. You get antibiotic every day, every place, in all the medical shops. And poor compliance. You start antibiotic for 2 days, you stop the antibiotics. That is called poor compliance. Recently I've heard people saying that people are getting antibiotics in the peripheral clinics. 1 dose of piperacillin tazobactam and going home. Will it be helpful? It is more harmful. Okay, that is the practice which is happening. That is the reason for antimicrobial resistance. And the last part is accumulation of resistance to multiple antibiotics. They are developing resistance. They are becoming superbugs. How are they developing resistance? Why do they develop resistance? You are all thinking this is the way. Okay? You have lot of germs in your body. The blue ones are, the pink ones are drug resistant, the blue ones are the other germs. So when you give an antibiotic, it kills the germs along with, there are some germs protective to the body. You should not kill everything, okay? So once you kill that, the pink ones, which are the resistant ones, they become more and more. The drug resistant bacteria are now allowed to grow and take over, they become more. And they also transfer the resistance to other bugs. So basically by giving a insufficient or inadequate antibiotic, you are killing the good bacteria and also helping the resistance to spread and grow over the time, okay? And this is an example how it spreads. So Mr. X gets antibiotic which he doesn't require and he develops resistant bacteria in the gut. If he gets infected, he goes to the hospital. From the hospital, either from him to the patients or through the doctors or the paramedical staff, he goes and it gets circulated back. These doctors or the other patients go to the community and they spread the resistance to others. Or if he goes into the community, he can develop the resistance. Similarly, there is a lot of antibiotic abuse in poultry and animal husbandry, okay? So they receive antibiotics for various reasons and they develop resistant antibiotics, resistant organisms in the gut. They, as consumed by the community, they give the resistance to them. Or they go into farming, they go in the form of pesticides and all that, it will go back to the community. That's how, you don't think about it, but that is how the vicious circle, this is called vicious cycle. So you need to break this vicious cycle, which we'll discuss later. This is how the antimicrobial resistance happens. There is a bacteria here. If you use the antibiotics indiscriminately, you're going to get a superbacteria. And how do they become a superbacteria? This is how they do it. There are basically 5 mechanisms. One is, whatever antibiotics you pump in them, they develop a pump outside. You give it to them, they throw it out. They are called efflux pump mechanism. Okay, I'm trying to be as basic as possible. The second one is, they can block the antibiotic entry into them. You give how much of antibiotic, there are some transporters outside their cell wall, and they can block it because they can block the transporter. Okay, so these are 2 mechanisms. The third mechanism is they can develop some enzymes. You would have seen BL, beta-lactamases, carbametases. They are the enzymes, and they can, with the help of these enzymes, they can break down and cause ineffective antibiotics. Other one is, all these antibiotics will go and act on the target site. Okay? If this is the target site, see here, they can change the target site and the antibiotics doesn't work. So these are the main mechanisms how they develop resistance. Okay? And another mechanism is, I'm sure you would have seen this. Where do you see this? This is biofilm formation. They form a protective layer around themselves and they prevent the entry of antibiotics. It's usually seen in indwelling devices like central line. Okay? Any other indwelling devices, there's a chance of biofilm formation. The biofilm formation, whenever it happens, it is very difficult to penetrate the antibiotics to penetrate that and treat it. Okay? So these are the 5 mechanisms how they develop the resistance. Is it clear? Once again, just so that you will remember, one is efflux pump. The second one is they block the entry. Third one is they develop enzymes which breaks the antibiotic effectiveness and the target site. The last one would be biofilm formation. So you know there is an antibiotic resistance. I have spoken over the slides. There is a need for change. But how do you prevent this antimicrobial resistance? What are the key prevention strategies? There are only 4. Remember these 4. When you go home, you remember this. One is you basically prevent the infection. Avoid the usage of antibiotics. Is it clear? It's simple. Prevent the infection, there is no need of antibiotics. Somebody comes with a respiratory viral infection who doesn't require antibiotics. He receives antibiotics. Viral infection, does it require antibiotics? Viral pneumonia? Again, it will lead to antibiotics. So you prevent that viral illness or infection, prevent the antibiotic use. Diagnose and treat infection effectively. Give the right antibiotic, right duration, right time. Third one is use antimicrobial wisely, and the last one is prevent transmission. That is the most important part which applies to all of us. And here clinicians hold the solution, but not only clinician, everybody who is taking care of the patients, they are responsible for prevention of antimicrobial resistance. So how do you prevent infection? Vaccination. So influenza and pneumococcal vaccination for the at-risk hospital patient will prevent infections, reduce the hospital admissions, unnecessarily administration of antibiotics. Then in the prevent infection part, you get all the devices out. So in the ICU, for example, we take rounds every day. Okay? So we look at all the devices which are there. How many days of central line, how many days of arterial line, how many days of Foley's catheter, how many days of tracheostomy. It has to be mentioned every day with the number of days of use, and it has to be seen every day, checked every day, look for any collection or any change in the color, okay, and also clinically correlate it whether that needs to be there or not there. Somebody who has a central line but it is not required because he is off all the higher support, vasopressor support. Okay, he has got another peripheral IV access. You take the peripheral IV access, try to get this out as soon as possible. Okay, the same applies to other devices like an endotracheal tube. Somebody is good, don't keep prolonged ventilation. If you can wean him and get him out of the ventilator, get him out of the ventilator faster. Same thing to Foley's catheter. Okay, there are instances where the central line has been kept forgotten in the ward. They'll be in the ICU, but eventually they'll move to the ward, and the ward it will keep on continuing and patient will develop. What happens because of the long-term use of central line? What do they develop? CLABSI. So you take out the central line, biofilm can form within 24 hours after insertion. So that is one indication where you have to think that this has to be regularly intervened and taken out. Okay. Use catheter only when essential. Use correct catheter. Proper insertion techniques and protocols are very important. Okay. If a doctor is doing the procedure, it's your responsibility to tell the doctors you have touched something else, you need to change the gloves. This needle has touched something else, change the gloves. Okay. And also you are seeing the patient every day. You need to check if there is a signs of infection in any of the lines. Appropriate antimicrobial therapy is very important. For that you need to culture the patient, and the techniques of culturing, everything has been beautifully explained by Dr. Spurti. Target the empirical therapy. Whenever you start the antibiotics, your empirical therapy should be a proper one. For example, if you are targeting the lungs, you need to know if it is a pneumonia, it has to be that antibiotic which has to cover. The same thing to gut, same thing to urine infection. Okay? And also most important thing is the infection control doesn't happen with one person. It is with the entire team. Okay? So it starts with the nursing team, the microbiologist, the infectious disease specialist, then the clinicians. If you correlate well, then only you will be having the best of the responses. Okay? So the local antibiogram, what the microbiology team does is the most important thing. In one part of the country there will be a different organism. One part of the state there will be a different organism. So our hospital, which is the most common organism, we need to know. Okay, that is done by local antibiogram, which will be done by microbiologist. Based on that only we start the antibiotics. Second one is you do all these, you send the culture, you get the reports now. So once you get the report also, you need to think whether this antibiotic has to be continued based on the sensitivity and the MIC pattern, whether I should continue it or to change it, or can I de-escalate it. Three things you have to think. Okay? And how do you decide? You also correlate with the clinical improvement. Somebody has received antibiotic for 3 days. No, he has to receive the antibiotic for another 10 days. There is no rule. Patient is clinically getting better. You can de-escalate the antibiotics based on the sensitivity and the clinical pattern. Patient's fever is coming down. His blood pressure is improving. In fact, you can always discuss with the doctors, the bedside doctors, sir, the patient is getting better. Do you still need these antibiotics? So, doctor, the antibiotic results have come. It's our responsibility that I have sent a culture. You need to constantly follow it up. Send the culture and forget? No. Follow it up. Doctor, this culture is showing this. Can I change the antibiotics? You develop that rapport. You're going to help the patient, help the doctors. The doctor will develop the confidence on you as well. Okay? And once you get the report, you target the definitive therapy for that. That is the second part. What is the third part? Use antimicrobials wisely. Practice antimicrobial control. So you need to develop programs like these so that you can improve the effective antimicrobial use. and also engage in local antimicrobial use quality improvement efforts. You need to hold regular meetings, infection control meetings in your hospitals, attend the infection control meetings along with the doctors and the ID specialists and the microbiology team, and implement the program. Use local data, as I told you. Our local antimicrobial bot is there. You use that local antimicrobial data and know your patient population. Whether this patient has come from other hospital, he has been undergoing dialysis, he has been undergoing chemotherapy, or whether he had a long-term catheter, this all we should know when the patient comes. Okay? As soon as he comes, that because somebody who is in the long-term hospital stay or is undergoing dialysis or all these risk factors, they are going to have developed multi-drug resistance pathogens. Otherwise, community acquired is different. Somebody coming from the community, no risk factors, antibiotics are different. You can start with the basic antibiotics. But somebody has a risk factor, then definitely you have to think for a higher antibiotic. Okay? Don't start these higher antibiotics to a community acquired. Similarly, a community acquired antibiotic, what is there? If you start for a high risk patients, it is not effective. Again, you are going to increase the resistance. Is that simple and clear? Know when to say no to higher antibiotics. You get the report, okay? Well, even the patient is clinically improving. It is sensitive to peptides, it is sensitive to meropenem. My meropenem, I believe in meropenem, and I vote for meropenem, I'll start meropenem. But it is sensitive to peptides. That is a wrong thing to do, okay? If it is sensitive, patient is clinically getting better, always say no to antibiotics, or can I completely stop it if he is better? So every day, every shift you have to think whether I can continue or stop the antibiotic. Stop treatment when infection is cured or unlikely. Don't continue it for a longer days like 10 days, 14 days, 20 days. Clinically, if you have any doubts, discuss with your doctor or the ID specialist and then take a call further. Okay. Finally, the last one is prevent transmission. I'm sure there's a lot of discussion on this. How do you prevent transmission? That will be a separate session as well. But patient to patient spread, doctor to patient spread can be done, avoided by using a proper isolation procedures and proper contact precautions, barrier nursing. All those things are a very integral part. I'm sure everybody is an expert in that, but it needs to be reinforced again and again. That is the most important thing. Contain your contagion and keep your hands clean. But I spoke about this antimicrobial resistance so much. Why do we bother about this so much? Why do we discuss? Why do we have this workshop? What are the implications of this? What happens? 4 answers I need. What happens? Okay, so one is you are not treating the patient effectively, so you are not going to cure the patient. It increases his morbidity and mortality. Okay, so the morbidity and mortality is going to increase. So whenever the patient is not getting cured, his length of stay in the hospital increases. He's going to stay for a longer time in the ICU, longer time in the HDU and in the ward. Mechanical ventilation length is increased. Increased need for intensive care. Sometimes they go into septic shock, you need to put new lines, then you need to put dialysis catheter, you need to dialyze. So the length of stay is increased again. They might need excess surgeries to control the infections. They can develop new infections. And there will be decline in the functional recovery, and you need to isolate them. You need to have a contact isolations. So that's going to again prolong this stay in the ICU. And what's the other important part? The cost. I'm sure everybody will know about this. The patients not having money, they get discharged against medical advice, go home or go to other centers. So if you don't use a right antibiotic, that's going to worsen the hospital stay, and there's going to be increase in resource utilization and also cost. So if you look at it, there's a hospital, ICU and post-acute care beds also is required more. So hospital is also going to have a decline in their resources. Additional nursing is required, support services are required, diagnostic tests, again cost, imaging, CT scan for them, again imaging cost. Okay. Again you have to keep more isolation rooms, again more gowns. All those things are going to add up to a lot of cost. No matter whatever insurance you have, you're going to drain it out. So this has to be kept in mind. Okay. And treatment failure, of course. If the antibiotic is not working, you're going to have a treatment failure. All the narrow spectrum, you're going to have the loss. Those whatever piperacillin, tazobactam, all the cephalosporin, all those things are going to have a loss. Nowadays the resistance is coming, as Dr. Spooty said, there is MDR, XDR and PDR. PDR is the most dangerous one. There is no antibiotic only left. He is at the mercy of the God, isn't it? At least MDR, XDR, there are some things we can work around, but PDR, there is nothing. So eventually, if you continue like this, the PDR is going to be very prominent and we're going to be in trouble. No matter whatever you do, you don't have the antibiotic to control the infection, the patient is going to suffer. Okay. Then there will be agents with reduced efficacy. Sometimes you might have to use some drugs like colistin and all. They are nephrotoxic whenever you use colistin antibiotics. So there is no choice, you have to use it. So those things will start happening for us. Sometimes what happens is there can be a chance of unit closures because Acinetobacter comes together, it spreads. So what do? We shut down one part of the ICU, we isolate them and start cleaning them. So you're going to reduce the number of beds and actually increases the burden to the hospital. Sometimes cancellation of the surgery because of infection, he is going to be in the hospital for another 1 week, again increased cost. So what do you think this is? We have drained out all the antibiotic here. There are few antibiotics here. Very last of us. Okay, use it very wisely. Otherwise, make better use of existing antibiotics. Finding new antibiotics is almost impossible now. We have seen the data in the last few years, very less of antibiotics have come in. And you concentrate on this line when you go home. This actually makes you think why we should have this workshop, why we should think about this so much, why it is so important, and why people feel that by 2050 it is going to kill more people. You know, he discovered penicillin, but you know what he said? The thoughtless person playing with the penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin resistant organism. He is morally responsible. If you are not using this antibiotic right, you are actually responsible for the death of the person who is not responding to this antibiotics. So that much important is the antimicrobial resistance. Okay. So it is our right, or it is you have to make sure that the antibiotics has to be used in the right way and follow all the 4 prongs. One is prevent infection, avoid the use of antibiotics. Second one is use the right antibiotics at the right time, right duration. Okay. The third one is implement new policies like these workshops and all and spread the awareness. And the fourth important point is prevention of transmission to the antimicrobial resistance like isolation and contact precautions. So if you follow this in a careful way, probably we can't prevent the natural resistance pattern, but at least we can slow the progression and buy some more time till then we get the newer antibiotics. Okay. There are newer rapid diagnostic techniques like BioFire, like Dr. Spooty said. They are going to give us a good early detection and also some resistant genes also. So if you use it wisely and if you implement in your hospitals, the chance of treating the patient the right antibiotic and also de-escalating will be easier. So these are modalities has to be used, and I thank you for this session, and any questions please go ahead and ask me.
Dr. Spooty will give a small moment of appreciation to Dr. Himal if there are no questions. Thank you, Dr. Himal. Next up is Dr. Divya. Another topic, this one. Thank you.
So I think by now people have scared you enough, and I don't have to do the honor of scaring you more. And so need of the hour at this point is don't use antibiotics when it's not required. And when you have started an antibiotic, see, when a patient comes critical, when you have suspected sepsis, time is the essence that time. So you start the antibiotic, okay? So we need a process which will guide from there what to do. Okay, so patient has gotten better, you know, your cultures which are showing you results, but you know, you just continue what is being started, then the whole exercise of, you know, Dr. Spurti explaining what and all miracles she can do in the lab and, you know, everything, doesn't make sense. We are just wasting time for the patient by, or probably even money for the patient by sending these tests when you're not going to use it for yourself, right? So antibiotic stewardship is about how you will make better use of antibiotics throughout the course of the patient. You just don't start somebody on something and just, you know, let it go, right? So it's a very dynamic process. Stewardship is a very dynamic process of what you do to the patient over the time. So you can say, okay, we don't have antibiotics, let's get new. It is not as simple as that. We will keep finding new antibiotics, but you know, what are the chances if you don't know how to tackle the resource? If we just keep getting new antibiotics, you'll just keep using it up and, you know, develop more resistance. So you should know how to utilize. It's like a natural resource. You should know how to utilize it to the maximum. At the same time, give the benefit to the patient. So see, what Dr. Dennis Markey says is the development of new antibiotics without having mechanism to ensure that it is appropriately used. It's like giving your alcoholic, you're telling him to stop antibiotics also, but again giving him a better, finer brandy. So he is not going to become stop being an alcoholic if you don't get him out of there. Okay? So you can, I think this Dr. Himar has this one, how much we use antibiotics. If you see, it is gradually increasing over the years, and see, it is partly because of the kind of patients we have. We have more immunosuppressed patients, more complex patients. I understand. Use of antibiotics is not the problem. Not doing anything about it after starting it is the problem here. So, antibiotic stewardship in a very simple way is, you know, you need to have a process which will help you optimize the correct antibiotic for your patient you're trying to treat. That is basically what you're trying to do. We are not telling you patient is very sick, give tablet, tax him. That's not what we are trying to tell you. We are trying to tell you if your patient is sick, use the correct antibiotic which will help them recover. At the same time, you don't do any collateral damage. Okay? So how do we do this? It is about selecting the right agent, right dose, right way of giving it for the right amount of time. Now, this is before the development. So now you have a lot of XDR bugs. So what is the solution? What is the long-term solution to this? One of it is you need new drugs. Okay, you cannot do anything about drugs which are already gone. You need to develop new drugs. But again, that is not very dynamic right now. We don't have much options at this point in time. You have better diagnostics. I think that Dr. Spurti was very efficient in telling how we can do it much, much better to get the results faster so that we can act faster and probably even come down on the antibiotics appropriately. Infection control to prevent. You have already started the cycle of antibiotic resistance. How you are going to stop the cycle. Next is education of the healthcare fraternity on what is the right thing to do when you have a antibiotic resistant bug. Next is research and policy and reduce resistance reservoirs like our poultry and animal husbandry, which has been explained to you. And the center of this at this point is antimicrobial stewardship. But you have to understand that these are all fitting into each other. So following one does not fulfill the criteria of others. Everything has to churn in the right way so that you can go forward. So this is a study. This is a very interesting study which they did back in, this is actually back in I think 1996, where they formed a group and used only third generation, to prevent inappropriate use of third generation cephalosporins. Imagine we were still in third generation cephalosporins then. That they interestingly noted that it drastically brought down the antimicrobial use and the cost for the patient over the year. this was the trend of the resistant infections going on with inappropriate, inadvertent use of antibiotics. Well, that started dropping, and even the rate of VRE, vancomycin resistant enterococcus, also started showing a dip. Just having a program of antibiotic stewardship is what is bringing about this change. Very prestigious guidelines like IDSA and Surviving Sepsis campaign consistently use this term de-escalate. Okay, de-escalation is the cornerstone for antibiotic stewardship. Now, what is de-escalation? It just doesn't mean that you bring down meropenem has to become ceftriaxone. That's not the only thing that is included in de-escalation. It means one is narrow down your spectrum. Okay, so I'll give you an example. You have a patient come with UTI, has E. coli. Okay, E. coli, and your microbial, you have started on meropenem. Fair, patient is in the ICU, you have started meropenem, good for you. But your microbiologist has, reported that all medicines, all the drugs are sensitive. So now you have to understand, one group will have so many drugs, okay, starting from the lowest spectrum, it goes up to meropenem, which will cover multiple organisms. But you have to understand a basic thing that joins all these things together into the group is the fact that they have the same mechanism of action. Okay, they're all beta-lactams. The beta-lactam ring is the one which is disrupting the bacterial cell wall and inhibiting its growth. Whether you give meropenem or whether you give cefixime, that is how it will work. Meropenem is not doing miracle over there. Okay, but what you have done is a collateral damage. What have you done? Your E. coli, which is on Parvum thing right now, has no exposure to any antibiotics. You have already exposed it to meropenem. Now what it will do, like how we say they develop resistance over time, you have exposed the bacteria to meropenem. Now it knows the meropenem exists. Okay, it knows that it's going to be harmful. So it will start. It's but natural for bacteria to start developing mechanisms of resistance. Okay, so what happens? This patient, now with that, all of you attend ICU rounds and things like that. So if you see, patient will be on 4 drugs. As soon as the patient comes, patient is on high inotropes, meropenem, ticoplanin, some 5 drugs are there. Again, time is the essence. You have to save the patient. Before culture report comes, you cannot let the patient die. So you start everything. So like Dr. Spurti told, you have sent a culture but started on meropenem, ticoplanin. Okay, she is already told your blood culture is showing GNB. So you know ticoplanin has no work against GNBs. So stop it. That is also de-escalation. Just having the courage to stop a drug which is probably not needed is de-escalation. Next is safety drugs. Safety drugs are basically restricted antibiotics, the higher antibiotics. Wherever you get an opportunity, bring it down, because they are like natural resources right now. And giving meropenem for a ward patient is preventing the same patient coming into the ICU to not receive the same drug. Okay? And stop. See, patient has come, respiratory distress, lung, chest x-ray looks very bad, patient is on inotropes. I understand. One of the differential is infection, you've started the treatment. Next day you observe that, the patient's x-ray is cleared, you have given a treatment for cardiac failure, patient is already better. So infection cannot be that fast. You have not even isolated the organism. So, you start ruling out, okay, so this was not an infection after all, stop the antibiotics. Okay? Or you had a respiratory infection, you thought it was bacterial, started, sent for H1N1, sent for COVID, it's come positive. Now you know it's a viral infection. Stop. So taking the decision to stop unnecessary antibiotics is a de-escalation technique. Therapy aimed at causative agent. So once the report comes, you know you can bring it down to the lowest antibiotic that you can give. And switching. So switching is a very interesting concept. So you have something for which you can give an oral option. Okay? So one thing you have to remember is if you're giving an oral medicine, you should make sure that it will be actually concentrating in the tissue that you're trying to give. Okay? IV antibiotics have a better tissue penetration, I agree. But there are medicines like linezolid and levofloxacin which has equal, if you give IV or oral, they have equal bioavailability. So always bring it down to oral if it is possible. Now you can ask why IV? It's the same, oral or IV Livoflox, it's the same drug, right? So there's a lot of chain of events that you're preventing. One, you have brought it down to oral drugs, you don't need an IV line, right? You don't need an IV line, you probably can remove the central line faster, you're preventing the patient from getting that infection and prolonging the hospital stay, okay? And another is, you can probably bring down the adverse effects associated with the IV preparation. I'm not saying the same molecule. If there is a molecule which has an oral downgrade, you are probably reducing the adverse effects associated with the previous injection. So you are basically switching to a better option so that it decreases. You can discharge the patient faster. You can tell the patient take the oral and go, right? So things like that can hasten the patient's recovery. So the ultimate goal, I think I've covered all these things, reduce the selection. So you're not giving an opportunity for the bacteria to become resistant, okay? So you reduce the selection of bacteria, reduce the colonization. So again, if you heard Dr. Himal, he said there are some good bacteria in your body, you're giving antibiotics to target something, but all these antibiotics will still act on the good bacteria as well. So you're making them resistant. So you're allowing your body to be colonized with an MDR organism, which will go into the community or even infect yourself. Worst case scenario, you're infecting your own loved ones at home, okay? So being colonized is actually worse because you don't have an infection, you have it and you're just giving it to someone else. Now, then colonization is one. Colonization is where you have the bacteria but you don't have an infection. Having an infection with MDR bacteria, and as I said, reduce costs. You know how much meropenem costs, you know what a lower antibiotic costs. You're reducing the cost for the patient, you're reducing the time to recovery. You're reducing the length of stay in the hospital, you're decreasing the mortality. Having a drug-resistant infection is always associated with a much more mortality, all right? So when you consider, it all depends on what antibiotic you're putting. So when the initial antibiotic which you put, you should be mindful of certain things. See, you cannot say, I will de-escalate later. I will anyways de-escalate later after the culture comes. That's not when you're choosing an empiric therapy, that should not be your attitude. Your attitude should be what is the correct thing for the patient in the whole scenario, keeping the whole scenario in mind. So, spectrum of coverage. So, patient has come with UTI. Okay, so you think what organisms can cause urinary tract infection? You try to give antibiotics which covers that. Next is pattern of resistance, okay? Now the pattern of resistance, this will depend on a good antibiogram, alright? Your hospital antibiogram will tell you what is the nature of patients in your hospital, okay? You have a patient who's come from the community and has a UTI. He's not expected to have any, resistant organisms. So you can start with a simpler medication. Patient is in the hospital for a long time, neurosurgical patient, tracheostomy, this got infected, came to the ICU. The chances of them having resistant bacteria is much more. So your antibiotic should target that. So you should always know your local antibiogram and know what to start as empiric therapy. Next is antibiotic policy. Based on the antibiogram, there will always be a policy drafted for your hospital. Please follow it so that you know what to exactly look for. PKPD parameter. Next is, you've given some drug, okay, so patient has UTI, but patient is very sick, is in the ICU. Nitrofurantoin is sensitive. You give nitrofurantoin, makes no sense, okay, because nitrofurantoin is going to concentrates only in the urine. It does not go to the blood at all. Giving nitrofurantoin is the correct. It will show it is sensitive, but you have to make sure you're giving a drug which will concentrate in the area of interest. You want to give a medicine which will reach the blood. That means your antibiotic should be able to penetrate that area. So you should know whether the antibiotic you're prescribing will concentrate in your area of interest. Okay, that is PK/PD. PD is about giving the right dose. If you don't give the right dose, the amount of concentration you want in the tissue is not reached. If you don't give it over the time prescribed, again you will probably not reach the level that is required. So all those, so that is why we say correct, right dose, right timing, right route of administering it so that you get the maximum impact of the antibiotic that we are using. Next is allergy. Knowing the allergy profile is important, otherwise, you know you're triggering an allergy. Toxicity, know your toxicity. You know you want to use colistin, it can cause nephrotoxicity. Your patient is having renal failure, giving colistin, you have to reassess. I'm going to give it, is colistin my only choice? Because it is given at the cost of a kidney. You're going to say to the patient relatives, kidney is gone, but if to recover, I have to give this. So you have to choose the kidney or the life. So, but before you make that decision, you are making that decision for the patient. So before you make that decision, make sure you actually want it or not. Next is, as I said, I've already told you IV versus oral. Make sure that, when you're giving an oral medication, it is giving the desired effect. Okay, if the patient is very sick, I'm not telling switch it over and give oral just because, I told. Doesn't mean that way. You should make sure that, they are bioavailable in the maximum time. Duration of therapy to the shortest time. There's no hard and fast rule that you have to give 7 days, 8 days, 10 days, nothing. Patient gets better, patient is ready, stop the antibiotic. Okay. Next is cost. Look at the cost for the patient. You want to treat them, or you want to give the highest antibiotics where patient says I don't have the cost and not treating it, or give the best option of antibiotics that is available, which will probably cater to his cost, in which case he's probably going to get better and go home. So at what level should antibiotic stewardship work? So now we know everything, we know what we have started, now what do we do with the patient who's on antibiotics? At one point is, you started the antibiotics, sent for cultures, waited for the antibiotics to act, reassess. Reassess at 48 to 72 hours, that will give you a window of how your patient has improved, right? At this point you can probably establish whether the patient has infection, whether the patient has a bacterial infection or a viral infection, whether your cultures will be ready, and so 48 hours is a time you have to probably look back whether you have a narrower spectrum of antibiotics, whether it is an infection, whether you can stop it for a viral infection. So these are the decisions which you can take it at a 48-hour time. And as I said, another time, okay, patient was too sick, we have a cultures which are, negative, we don't know what is happening, we don't want to stop antibiotics. These are practical problems. So what you do, the next pit stop for it is when you're transitioning patient care. So patient is well enough to get out of ICU, was very sick, came with multiple inotropes, everything, you've started antibiotics, patient has improved and is fit enough to go to the ward. That means he's also fit enough to stop antibiotics or bring down the, spectrum. Okay. So as I said, that 7 days, 10 days is not written on stone. Okay. So as soon as the patient is better, if the patient is ready to go to the ward or home, that means that the antibiotic has done its job, right? So it's time for you to stop the antibiotic as well. Then don't give antibiotics which have the same coverage. It doesn't make sense. It's doing the same job, but you're exposing your bacteria to 2 different antibiotics unnecessarily and probably increasing the chances of getting resistance. Next is, there are some organisms for which you have to give double coverage. You have to give 2 antibiotics, but make sure you're giving it from 2 different groups so that they don't have, the same activity or the same way of resistance. Okay, so I think I've told about this enough number of times. Next is always ascertain whether you are dealing with the bacterial infection or a colonization. Alright, so if you see, if the patient has stayed in the hospital for enough amount of time, okay, he is likely to be colonized. Okay, so you have a patient who has asymptomatic bacteriuria. Now, if there is a Foley's catheter, patient is stable, no fever, no turbidity, WBC count is okay, but for whatever fun and joy you sent urine culture and came positive, it doesn't mean you have to treat it, right? Patient is stable, why do you want to treat it? First of all, why did you send the culture is the first question you should ask. So, when you get the culture, you are tempted to treat. So, you have to, that decision to not treat is also very important. It's very easy to treat, I don't have to be an ID to read the culture report, I know whatever it's given, I can treat it. the decisions to not treat, decisions to switch over therapy is what makes the difference. So you have a tracheostomy patients, you have put it for whatever reason, for neurosurgery, for whatever. Again, they will be colonized. So the fact is that as soon as a patient comes into the hospital, within 24 hours, especially if you are in an intensive care unit, they will get their whole respiratory tract is going to be colonized with bacteria. Okay? So that doesn't mean, first of all, again, if you send a culture, it will grow. Okay? If you have sent a culture, you have to substantiate whether you need to treat it or not. So always make sure that it is not a colonization. Chronic wound, which can also be covered with bacteria, any of the ulcers, chronic lung conditions like bronchiectasis and things like that, which can breed organisms, but it may not be causing the infection. It may be difficult to treat. Yeah, I mean it's difficult to differentiate at some point, but using clinical parameters, whether patient's ET culture has grown. Does the patient have fever? Does the patient have increased secretion? Is the chest X-ray bad? Is the patient having fever? So when you put the whole clinical picture, something will, if there are any parameters suggesting an infection, it's fine. But when everything is all right, it's an indication not to treat. Again, viral infections, I've already told you, multiple times, you start off antibiotics for a viral infection, stop it. First of all, on an OPD basis, when a patient comes with a URTI, it is viral, period. Okay, no starting Azi, no starting Augmentin. Those are very bad practices. Now, other things that you have to, I'll tell you why it is important. You have to, all of you, each one of you, after you go tomorrow probably, ask what is our antibiogram. Okay, all of you should have an antibiogram in hand. All right. If it is not there, catch the microbiologist. Okay. Ask where is our antibiogram. Okay. That is what determines therapy. Not having an antibiogram is like, going on a road with no traffic. I mean, no traffic lights. You can just be going anywhere, wherever you want and put anything you want. Having an antibiogram will clearly tell you what antibiotics to expect and what can be given for the betterment of the patient. So the homework for you all is go ask your hospital staff, hospital authorities, where is the antibiogram. Okay, that will help us de-escalate also. I'll tell you where that comes into the picture. Of course, diagnostic stewardship covered by Spurti for us. Now, what we do in Apollo Hospital. So, see, there is a prescription of restricted antibiotics. Okay, so we ask the prescribing physician to justify why they are giving it. Okay, so you should be held responsible. See, sometimes what happens, just writing down on a paper that I have used for unnecessary reason itself is a reason they will not give it. Okay, when I know this particular consultant has started for a viral infection, he knows that he's going to be judged for starting that antibiotic. Just making them write a restricted antibiotic form itself is one of the stewardship measures. So of course there is a notification going from the pharmacy to infection control team. So RA form goes to the microbiology, and also this notification to the infection control is followed by seeing if appropriate cultures are sent. By now we have established, one of the most effective way of de-escalation is getting a culture which is positive. So boldly we can tell them, see, you can de-escalate. Okay, so appropriate cultures are sent or not. If it is not sent, again put in a process to find out why are we not sending enough. Okay, so it's going to help us de-escalate. Why not send enough cultures? So get a process in place. So if there are adequate cultures sent, follow it up over the next 24 to 48 hours. Bug your microbiologist. Ask, I want to de-escalate. If you have a microbiologist like mine, she's going to make you only do it. She's not going to leave you till you have followed up the result. So you have to know your results and start preparing to de-escalate. As I said, at least de-escalate one drug which is not required. Then the next day bring it down to the narrowest spectrum possible. Next is, after 72 hours, now you have a culture which is positive. Now the doctor gets intimated, the infection control committee gets involved, and a narrowing of the antibiotic is expected. Out of them, Okay, otherwise we come into place, we talk to them, we ask them, can we de-escalate? Is there any reason why we should not? Is there anything we can do? Why you don't want to de-escalate? If there is a wrong process in place, probably correct that. So this is when you have a culture which is positive. You have a culture which is negative. That's a very difficult scenario. You don't know what has worked. I don't know if this is working. I don't know if there is a lower antibiotic available. Patient is still sick. Things like that are practical challenges. I agree. It's very easy to say patient is improved in the last 48 hours. Why can't you de-escalate? Doesn't happen that way. I know for a fact that, you're still worried. Patient is still borderline. You don't know whether, the antibiotic what you prescribed actually made the impact. So in which case, again, we ask you to re-evaluate. Look at it. Is it infection? Is it viral infection? Is there any way we can still, you have got another report, cultures are negative. Do you have another report? Do you have a malaria test which is positive? Do you have a viral test which is positive? Do you have a rickettsia test which is positive? If those are positive, why do you need antibiotics? Okay, that becomes a pathway for your de-escalation. Next is after 72 hours, you have a complete report, it's negative. If there is, we still look if there is a way. Patient has got dramatically better. Is there a way we can? It's a difficult thing, but we can at some point. As I said, at least at this point, we can evaluate whether we can de-escalate if cultures are negative. So having said that, this is the clinical portion. Actually, all these are the interesting portions of antibiotic stewardship. There's dynamically something happening. Somebody can sending cultures, we are following it up. Can we change the antibiotics? This is very interesting. But antibiotic stewardship has a lot of boring things happening in the background as well. So like for a successful antibiotic stewardship program, you need to have a few things in place. You need your hospital leadership to be as committed as you to curbing resistance. So they need to provide you with all the freedom and the resources to combat antibiotic resistance. Accountability, whoever is prescribing should be held responsible for what they are prescribing. So that is where it matters to make them write an antibiotic form. They know what they are doing. You are telling them you are doing this, okay? So holding them accountability. If you actually look at an antibiotic stewardship program, the equal partner in this is also a clinical pharmacology side. So they are important players in it. Action. So, you escalated for one patient, you didn't escalate for another patient. All has to be documented. You need to have to see who got de-escalated, how many got de-escalated, how many got de-escalated, yes, last month, how many got de-escalated this month, so that you have a trend of what you are doing with it. So auditing is also very important. Tracking, auditing, reporting, all of it to see how your trend of de-escalation is going on, okay? And at the same time, so once you know, okay, we are not de-escalating as much, now you sit back, sit down, think why are we not de-escalating? Is there anything else we can do? Are we not sending adequate cultures? Are we not investigating for something else better? So things like that you have to start finding out and probably put that in place. And of course, it's a continuous process of education to keep telling you, de-escalation is important, this is what is expected out of you. It is a continuous process, it's a continuous challenge which has to be taken on an everyday basis. So the bottom line is only this much. Now antimicrobial resistance is a real thing. It's not like, earth is flat or anything like that. It is a real issue that we are, we are really facing that. It's a public health threat. Antibiotics has to be, as we have stressed so many times, there is no new antibiotics coming. We have to use our old antibiotics with caution, and antibiotic stewardship is one of those things which will help you preserve these antibiotics better. So it's in how we fine-tune the process. As I said, nobody is telling you not to use antibiotics. Nobody is telling you not to treat your patient. It's about how you handle it, how you can fine-tune the treatment for the patient. Thank you. Any questions?
Thank you, Dr. Divya. If anybody has any questions, you can ask now, or we can break up for lunch.
See, all of you heard how the infection control practices, the laboratory report, and the antimicrobial stewardship are practically implemented in ICU. We had Dr. Himal describing it in detail, and we had Dr. Divya who described how to implement an antimicrobial stewardship, what are the components of it. I think go back to your hospitals and see what it has been done about these two. I know infection control is a very boring part for many of them, and infection control nurses, infection control team are being a torture for all other hospital departments. Like, why will these people come? Why will these people question us? Who are they to question us? It is our department. We do whatever we want. But you know, it is boring, and maybe it is like interventional for other departments, but we can't help it. It's a big responsibility because the MDRs, XDRs, and PDRs are getting circulated in the community. Unfortunately, I see a lot of XDR cases even from community. Once a patient acquires an XDR or a PDR and goes back to the community, he will continue to spread it to others. So for that sake, rational use of antibiotics is very important. So go back to your hospitals, implement it, and make the best use of the current talks in your future practice. Okay. Thanks. 1 second. You have a question? Yeah.
Ma'am, there were so many things like de-escalation and all that on antimicrobial resistance. Is there any role of probiotics in de-escalating the
You're talking about
antibiotics?
probiotics or procalcitonin?
Probiotics, ma'am.
Probiotics. Okay.
Yes.
So probiotics is mainly to, you're telling whether it
Yes,
protects
because,
the gut bacteria.
because when you were telling, ma'am, we can take it into oral and all that,
Right.
but still when we have to reduce antibiotic, there are good bacteria which is equally killed. So is there any supplementing of probiotics
So
that
that's
could help
right.
reducing antibiotics?
Right, I understand. So there has been a lot of, it makes sense, right? You lost your good bacteria, you replace it with probiotics, it will colonize your, it's not as simple as that. The abdominal bio data is much more complex than that. And supplementing with probiotics at this stage at least is not beneficial. Yeah, it is more to prevent maybe side effects. Yeah.
Thank you.
So it's very difficult to say, all right? So once you have not acted on it, okay, and you have not tried to treat it, you usually circulate it out of your system, okay? So, but you have to take precautions not to take it back home, okay? So once you are resistant, it's not like you can do anything about it, but even being cautious at home and all those things, it's about how you will spread it, okay? But you will definitely get over the resistance, yes, over time.
Anybody else? Any questions?
It's okay? You want to?
Check.
ಊಟನಾ? Okay, anything else? Okay, just give us 2 minutes to coordinate lunch. Hello. So the lunch is arranged outside. Please get your lunch and you can probably have it inside. Otherwise, it will get crowded outside. Yeah.
ಈಗ ಸ್ಟಾರ್ಟ್ ಮಾಡೋದಾ ಬರ್ತೀನಿ. Good afternoon, everyone. Good afternoon. I'm Dr. Pradeep, intensivist from Apollo Hospital, Sheshapuram. First of all, I would like to thank Dr. Divya and Spurti for giving this and team for giving this opportunity. Okay. I hope this will be useful. I'm not take much time. There are a few colorful slides. Okay. This will be the two-way interaction class. So this is one of the most common things which we see in ICU. Those who are working in ICU probably they will be knowing this. This is called ventilator-associated pneumonia, also known as VAP. Okay. First, you should know what is VAP. Normally, many patients, more than 50% of the patients who comes to the hospital, they will not be infected. Other than infection, there are so many diseases like we have stroke, we have heart attack, and we have fractures, RTA. They come to the hospital without any infection. Okay. If the patient has stroke, he has come with only stroke. The stroke is not an infectious condition. But once they enter into the hospital environment, they may get infection. Okay. If they get infection after 48 hours after admission, if they are not having infection, if they get 48 hours, this is a hospital acquired infection they call. Suppose the patient comes with stroke or MI, heart attack, he has pulmonary edema, breathing difficulty, we put on a ventilator. Or the patient has stroke, he is having unconsciousness, to prevent aspiration, we put on a ventilator. If these patients get infected, because stroke is not an infected condition, if he gets infected, that should be after 48 hours. Within 40 hours he has infection, probably it is he had infection probably before coming itself. According to the definition, he should have infection after 48 hours after mechanical ventilation or intubation. Then it is called ventilator associated. There should be ventilator, there should be pneumonia. That after when the patient comes to hospital, you intubate the patient. From the intubation to the 48 hours, if he has infection, that is a ventilator associated pneumonia. Okay, this one you should know, because because of the ventilation he has developed infection. But why the patient after putting the ventilator he should develop infection? There are some criteria, there are some things which will define why the patient get infection, and we have some factors which we can avoid this. Okay, before going this, you should know what is the difference between VAP and VAT. VAP is ventilator associated pneumonia, VAT is ventilator associated tracheobronchitis. If they have inflammation only the airways without any lung involvement. So I will explain you in subsequent slides regarding differentiation, but only difference is in VAT, ventricular tracheobronchitis, they will not have any lung infiltrates, or X-ray if you see, X-ray will be normal. But other features will be same. We'll discuss what are the other features. So always we'll come to see. Okay, and one more thing you should know, what is called early VAP and late VAP. In the VAP itself, they are divided into two slides, early and late. Patient has come to the ICU, we have intubated him. For 48 hours, there is no infection. After 48 hours, he started getting infection. From 48 hours, that is from second day to the 5 days, if he gets infection, that is called early VAP. After 5 days, if he gets, it's a late VAP. Why they have done this classification? Because if the patient gets infection within 2 days to 5 days in between, and if he gets infection, these infections are usually they are very sensitive infections. Means they are not drug resistance or not a very serious infections. If he gets early infection, these are all treatable infections. We can treat him with the simplest antibiotics. If the patient gets after 5 days, probably they are very resistant organisms. We require higher antibiotics. For that reason, they are given this classification. So why we should have, why it is very important? Because if you see the VAP, 25% all the nosocomial infection in the ICU is because of the VAP itself. We have urinary tract infection, we have blood catheter related infections. If you just consider VAP, it's only is up to 25%. And second thing, see, he has come with stroke. We have given the VAP, and these patients, up to 50% of the patient, they can have mortality and morbidity. He may tell, we have come with a stroke, you have given the infection. Because of the infection, up to 50% of the patient can die. One thing. Second thing, we have come for the stroke and we are treating for the stroke. Because of this infection, there is mortality is high and they have to spend extra cost burden to the patient. Okay, this is also important. And always remember, it is a preventable condition. It's a preventable condition. We can always prevent it. So, and when we know that we know definition, when we should know how and why the patient gets infection. Not everybody gets infection. Up to 74% of the patient may not get infection. Only 25% they get infection. There should be some risk factors to get infection. What are these risk factors? If you see here, there's a doctor and nurse here. There's a one entity, and we have a patient. In between, we have a ventilator and the tubes. So these factors are divided into three things. One is the patient-related risk factors, tube and ventilator-related risk factors, and the person who is giving care of the patient, the doctor-nurse-related risk factors. So these are the risk factors. Okay. So just if you see first we'll take the patient-related risk factors. If you see the patient-related, if the patient is very old, or patient is malnourished, patient is immunocompromised, patient having prolonged hospital stay or ICU stay, the patient having multiple multi-organ involvement, or the patients already treated with antibiotics. These are the patients who are high risk for VAP. The patient who is coming first time, young patients, no other multiple comorbids, no immunocompromised status, they will not get easily. These are the risk factors from the patient related. If you see the healthcare related this thing, suppose if we are not using proper care, we are not using gloves, or we are not sanitizing our hands and then touching, or not with unsterile things we are doing the procedures, oral care, touching, doing suctioning. These are all the doctors related risk factors. What are there is some device related risk factors we'll see later. Okay. So what will happen when the patients are intubated? There are so many organisms which can colonize the airway. So many organisms they colonize the airways, and some of the organisms they can colonize the gut. If the patient is intubated, the cough, he cannot cough properly. So all the secretions which along with the secretion, the infections goes and collected above we have that cough. Slowly they trickle down and they cause infections. Suppose if we have a crust on the ET tube, normally when you give antibiotic will go to that site with the blood supply. Suppose if there is any secretions which are sitting on this ET tube, and the antibiotics cannot enter there. That's the crust formation. When we do suctioning, we are pushing the secretion into the lung and they can cause infection. So how we can prevent? So first we have to avoid the colonization of organisms in the airway. We have to avoid colonization of the organisms in the stomach. That's the one way. Second, we have to avoid the regurgitation of the secretions. That's the second thing. And then we have to do regular suctioning, cleaning and supraglottic suctioning we have to do. And then when we are doing the suctioning, with the suction catheter also we can introduce the infection. We have to avoid that unhygienic way of doing suctioning. So in this way we can avoid. And along with that, we have to make the patients properly, good nutrition should be there. That is also very important. And we have to simultaneously treat the other organisms. So if you are asked, how will you diagnose the VAP? See, VAP is an infection in the lung. How we are going to diagnose infection? It's very easy. If there is a patient has infection, he will have fever, correct? WBC count goes high, correct? Okay, he will have the fever, WBC goes high, and he will have secretions. You get secretions, correct? Then see, we have WBC counts goes high or low, 3 or 11. He will get temperature, he will get secretions, and then you remember, if the patient on ventilator, oxygenation, everything is okay with normal 40%, 50% or oxygen is maintaining, suddenly he started deteriorating and the oxygen level, that requirement goes high. That is usually these are the first sign of VAP. If the patient suddenly requires higher concentration of oxygen, he was actually 40% oxygen, now suddenly requires hypoxia. That is it. So how to diagnose in bedside? It's actually more of bedside diagnosis. You should see the oxygen requirement is going high. If there is any infection, you will not have proper oxygenation, correct? So oxygen requirement goes high. Patient will have fever, the WBC count goes high, and the secretions will increase. These are bedside diagnosis. If you see the X-ray, there will be have infiltrate. Some patch or a bilateral infiltrate. Okay. Then if you send for the bronchoscopic lavage or if you send for aspiration for this thing, you should be able to grow the organisms. So these are the 6 criteria to diagnose VAP. So for every criteria they have 0, 1, 2 points. For every criteria they have 0, 1, 2 points. This is called CPIS score, Clinical Pulmonology Infectious Score, CPIS score. For every criteria we have 0, 1, 2 points. If we are having 6 or more than 6 points, that is a highly suspicious of VAP. Okay, it's a very simple. Patient should have fever, patient should have high TLC count, patient should have increased secretion. Okay, then he should have patches in the lung, and then he should be able to grow the organisms, and the patient suddenly require high concentration of oxygen. So remember, 6 or more points. Actually, whenever you take rounds, always you should see this score if the patient on ventilator. In this score, we should be able to identify early the patient getting VAP, so that if you identify early, we can treat early. The duration of stay on ventilator, duration of stay in ICU, the financial recovery, everything will comes down. If you delay, he may go into the multi-organ failure. So this is called bundles. Bundles means these are the things which are used to prevent the VAP. With best of the ICU, best of the things, we can't avoid VAP, but with the bundles we can reduce the incidence of VAP. They are called bundles. See, for anything there are 100 of things which can reduce the VAP, but there are some things which are called bundles. Bundles means which have found mortality and morbidity benefits. Then only they are called bundles. This is called the bundles. We will see what are these bundles. There are 4 bundles. So what we have to do, always, you have to remember, always keep the patient head up position. That's why in ICU is a dictum. Whenever the patient comes to the ICU, if he doesn't have any cervical injury or something like that, make sure that all patients should be 30 to 45 degrees. We should not tell that. We should always remember that all the patients should be 30 to 45 degree head up position. That's called one bundle. Next, this is because it will prevent the regurgitation, aspiration. Second, there will be colonization of the organism in the throat, that will go to the lung. If you give proper oral care, we are reducing the colonization of the organisms. That is called chlorhexidine mouth care. That's the second bundle. Here, I will tell you this thing. Stress stressor prophylaxis. We will tell one by one. We'll just go. So these are all simple bundles. So head and elevation. Why you should do head and elevation? Because most of the patients in ICU, they will be little drowsy, unconscious, something like sedate or something like that. So we know that the organisms will colonize in the throat and in the stomach. So when we make it flat, they can regurgitate and the organisms will go into the lungs. So this is one of the proved thing. That's why I always keep the patient 30 to 45 degree head up positions. So this is the first bundle. So in this way, so this is how this ET cuff, this is how they trickle down and they cause the infection. So they have recommended DVT prophylaxis. How it is going to help in VAP? You can ask. The DVT prophylaxis is one of the bundle of VAP. See, whenever this thing is not going to act directly. The thing is, whenever we keep the patient head up position, there will be venous pulling in the lower limbs, and these patients are more prone for DVT. That's why in this they recommend DVT prophylaxis. DVT prophylaxis directly is not going to help the VAP, but because of the venous pulling, because we keeping the patient head up position, there will be venous pulling. They are more prone for deep vein thrombosis. Sometimes they say small thrombus in this thing, they can go into the lung, they cause some kind of inflammation or something related to the VAP, but basically it is mainly to prevent the deep vein thrombosis. That's why the DVT prophylaxis is one of the indication for the VAP. Peptic ulcer prophylaxis. As I told, the organisms can be there in the stomach which we regurgitate and then we can cause the VAP. So with giving this prophylaxis, they are increasing the pH of the stomach. So that's indirectly we are reducing the colonization of the organisms in the gut. This is one of the bundle. So remember this: head up position, DVT prophylaxis, peptic ulcer prophylaxis. The fourth one is oral care, chlorhexidine mouth care. That's why for every patient, if you advise or not, you should do chlorhexidine mouth care 2 to 3 times properly, DVT prophylaxis, stress stressor prophylaxis, and head up positions. There are so many other they are included in but they are not bundles. They are all the additional features which can reduce the incidence of VAP. Okay, sedation interruption. why the sedation interruption is the important in preventing VAP. What will happen? If you keep on sedating the patient, what will happen? You can't remove, see, as long as the tube is there, they can get infection, correct? If you keep on patient continuously on sedation, what will happen? The cough reflexes will be reduced. Cough reflexes will be reduced if the patient still has sedation. So when the cough reflex is reduced, he can aspirate more and he can get an infection. That's why if the patient on ventilator, first 1 or 2 days you give continuous sedation. Later we have to go, that is called sedation vacation. You have to give sedation intermittently, not continuously. Even if you give the sedation, make sure that the patient is conscious with the sedation, not completely knocking off or not. He is conscious but not able to pull out the tube or not knocking off all the reflexes in the throat. So thing is how to prevent, make the patient head up so that he can prevent aspiration. Okay, you give DVT prophylaxis, you give gastric ulcer prophylaxis, and then mouth, chloroxetine mouth care you have to give, then sedation interruption you have to do this thing. And if you have subglottic suction into ET tube, you can do the subglottic aspiration intermittently to prevent that one. So that is called, what is the optimal sedation? Make sure that the patient is awake and cooperative. That is the level of sedation you have to give. You should not give so much sedation so that the patient becomes unconscious kind of thing. And able to maintain the cough and swallowing reflex. Okay. That's called sedation vacation. Oral care, chloroxetine mouth care, that's what we use regularly in all the interpreted patients. We use the chloroxetine. And then make sure that the most common, and one way of preventing ventilator pneumonia is using the NIV. That's why they say any immunocompromised patients or patient who renal transplant, liver transplant patient who comes with the infection, always try to avoid the intubation because intubation is the risk for pneumonia. Try to use non-invasive ventilations. As much as possible, use non-invasive ventilation. If you still not work, patient not responding, we can go for the ventilation. Others try to avoid intubation. So all these things to happen in the ICU or hospital, we should have a team. We should have from the infectious control team, microbiology team, we should have. Then infection control nurses, then link nurses, then ICU, in charge of the ICU head nurses, then other assigned nurses. So the thing is, if we have a proper team, then they can analyze, they can take the data, they can see, then they keep on repeating, like they can have a regular meeting and they can advise what is going wrong, are we doing properly, something like that. So to have a best outcome, we should have a team. That's what they're doing. We should have a best team so that we can tackle it wherever it's possible. And in this, we don't have hand hygiene and then isolation. So this is the universal, okay, universal thing. We should not forget. So without hand hygiene. So always make sure that these are universal, which are not in the bundle. We should have a hand hygiene and we should use proper isolation techniques. Okay, we know the definition now. We know the risk factors. We know how to diagnose, and then we'll see how to treat. Treatment probably is not for the nurses, but you should remember this. See, we have divided the VAP into early and late. You understood it? From 2 to 5 days is early, and 5 to 7, more than 5 days is late. Always remember the early VAP, the organisms are usually sensitive organisms, and for them they require only the simple antibiotics. You don't require very higher antibiotics. For a late VAP, we require a combination of our treatment, and we require higher antibiotics, meropenem, colistin, something like that. We should have a higher VAP. Summary, so VAP is an important cause of death. Up to 25% of the death in ICU is because of the VAP, and they have increased morbidity, mortality, increased cost of care, health care, everything. So it's a preventable condition. Always remember the bundle, so that these bundles are used, and then you should know why we are using that bundle, so that we can prevent the VAP. So it's a very bedside condition. What we have to do if the patient on ventilator, if the patient suddenly patient requires higher oxygen concentration, probably that's early sign of VAP. Or patient stable, it's a stroke patient getting fever, it's a VAP. It's one of the reasons for VAP, it's not a VAP. Even the stroke itself can produce fever. So if the patient having a TLC going high, temperature going high, secretions are increasing, there is some this thing, and probably you have to suspect the VAP. Okay. Thank you.
Thank you, Dr. Pradeep. If you have any questions, you are free to ask them now. Any questions from the audience? No? Dr. Jagdish, please give a small moment of appreciation to Dr. Pradeep.
We would like to appreciate a few more people who have helped us a lot in the last 24 hours, and I think it's time to acknowledge them. One is Dr. Nagavalli, helping us with all our. She's been one of the backbones for us to arrange this. Please, Nagavalli. I invite Dr. Pradeep to please honor her. Another is our, for the MC for the day, Dr. Nisha. Again, she's been of utmost help and would like to appreciate her for that. I request Purti to do the honors. There's a small change in the plan, so to avoid the time constraint, those who have registered for the quiz, please stay back. The others can divide. One of you take this one. The rest of you can assemble down for a facility tour. It was just to see how we are doing certain things in the hospital. Maybe you can pick up a few practices which you can take it back home. As I said, having a strong infrastructure makes a lot of difference, and our facility manager will help you with it and tell us the various processes, and maybe something better, or you can come back and tell us what you are doing better so that we can adapt the same. Yeah. How many people are there you see? Where my phone is. We will not pair you, we will make it into groups. We will pair you. Can you call them out? Yes, ma'am. Call them out. And whoever is. Beda. Illa ache.
எப்படி மேம் குரூப் டிவைட் பண்ணுறது நம்ம? அதுவே நம்ம சாட்ஸ் அரேஞ்ச் பண்ணிடலாம்.
Velu idhar. Okay, sorry, back to the original plan. We will divide you into batches and send you one set of you will go to CSST, the rest of you will be, most of you will be with the facility, and about 20 people will go to CSST. So we will arrange it, okay? Okay.
The people who wants to see CSSD has to change your. So we have kept the scrub suit. Okay. We have kept a scrub suit. Without scrub suit, our CSSD in charge will not allow you. So it's ready. So CSSD people can segregate that side. We will take you. So our CSS is the best CSSD. National level, he got award also.
Aga dress change. Dress change. Nikkituma. Okay, then quiz ಅಷ್ಟೇ ಎಲ್ಲ
அது full நம்ம இங்க அரேஞ்ச் பண்ணிட்டு
நான் பண்ணிடுறேன்.
அப்புறமேல we will call.
நீங்க ஏதாச்சும் சொல்ல நினைக்கிறீங்களா? Nandini.
Is in individual visa.
இல்ல group.
So after quiz, just going.
That's it. It will take
Certification.
certification. You can come back and collect it.
From very far.
Yeah. No, you can give her. I'll give. Five members inside. Divya ma'am. Ma'am, ஒரு பொண்ணு white field-க்கு போகணுமா? time ஆகுது. Certificate கொடுத்துருங்க. Everybody can take.
Just added Chaya in this.
Your
Chaya.
Chaya. Okay.
Or ma'am.
Sure.
Means it's a group team.
ಸೆಟ್ ಬರುತ್ತಲ್ಲ
Answer single one.
ಒಂದು ಸೆಟ್ ಬರುತ್ತಲ್ವಾ ಅದು ತಗೊಳ್ಳಿ.
அக்கா அப்படியே நந்தினி இருக்கா பாருங்க.
இருக்கு. There's one more Nandini here.
ಅಶ್ವತಿ ಸೈನ್ ತಗೋಬೇಕು ಅಶ್ವತಿ.
She has written, she remembers all the names.
All these are linked nurses.
Oh my god, so good.
She is our deputy nurse.
Dr. Santosh, thank you so much.
We'll take a pic of
Sharon, நான் மெயின் பில்டிங் போயிட்டு வரேன். ஓகே, நீ கால் மீ இங்க முடிஞ்சதுன்னா
ஓகே மேம். You can stay inside. I'll come and give you. I'll call your names. Okay, you can stay inside. We will call you. I'll call.
Hospital name, I wrote TWH. I didn't write the full name.
Let me check it out.
M. Ranjini. Can I check?
Ranjini. நீங்க படிங்க நான் கொடுத்துறேன்.
இதுல புக் எடுத்துட்டா
You can go to ground.
you write it, no problem, we'll take it later. வா யாருக்கு அவங்க கொடுக்கறதுக்கு
மேடம் கூட ஒரு பேட்ச் கொடுப்போம்.
இதுக்கு சர்டிஃபிகேட் எல்லாம் ஒன்று டிஸ்ட்ரிபியூட் பண்ணிடலாம். அவங்க எழுதினுங்கிற பாதி
இப்போ இல்லை, அவங்க வந்த பிறகு தான்.
திவ்யா பின்ன எப்போ கொடுக்குறது?
யாருன்னா போகிறவங்களுக்கு மாத்திரம் தான். இப்போ எல்லாம் முடிச்சுட்டு குவிஸ் முடிச்சுட்டு எல்லாரும் போகிறாங்க.
அர்ஜென்ட்டாக போகிறவங்களுக்கு மாத்திரம் தான். அர்ஜென்ட்டாக யார் போகிறவங்க இருக்கிறாங்க? எடு எடுங்க. எங்கே போகணும் நம்ம?
இப்போ நான் 10 பேர் தான் சிஎஸ்எஸ்டில் லோடு.
ஆமாம்,
ஒரு 10 பேர் ஒருத்தர் கூட்டிகிட்டு போகணும். ப்ளஸ் இவங்க அருண் இது கூப்பிட்டு போவோம்.
மெயின்டெனன்ஸு ஃபெசிலிட்டி
ஒரு 10 பேர் இங்கே முடிச்ச பேர் ஃபெசிலிட்டி அந்த மாதிரி பண்ணணும்.
சரி
சரி, எனவே குவிஸ் ஒன்றும் இல்லை
இல்லையா?
ஓகே, ಎಲ್ಲ முடிச்ச பேர்
ಇಲ್ಲಿ CSSDಗೆ ಹೋಗಿದ್ದಾರೆ ನೋಡು. ಹೌದು,
ನಂದಿನಿ ಆರ್.
Or you sit there. There. Yeah. 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 Team 4, can you be here? Who is team 4? Come here, come here. Can come here? No, shift here. Okay. So what? Your team 4, 6 of you. 6, 5, 5. So 4, 5, 6. Correct? Okay. This team has 6 members. Is that okay? Okay, fine. 1, 2, 3, 4, 5, 6. So, yeah. 1, ma'am, 1, 2, 3. These 1, 2, 3. Then again 4, 5, 6. Oops, sorry. So there'll be 3 rounds. Okay, listen to the rules. There'll be 3 rounds. First round consists of multiple choice questions. Okay. Second round will be a buzzer round where one who raises the hand for the first time will get the question. For the who raises hand first will get the question. Third will be picture, image, identify the image. Okay. So each right answer carries 4 marks. If the question is allotted to team 1 and it doesn't answer, and 4 marks is. If the question passes on to the next team, it's going to be 2 marks for them. For direct question, it's 4 marks, but a pass-on question, it's 2 marks. Okay, there's no negative question. Okay, hope it will be a learning session for all of you. All the best. Okay, a big round of applause for everybody. Team 1, okay. Others, please maintain silence. Don't whisper among yourself. First question is the definition of healthcare associated infection. So all of these are correct, except all of these are the criteria for HAI, except first is infection acquired in the hospital by the patient admitted for a reason other than the infection in context. Infection should not be present or incubating at the time of admission. Symptoms appear at least after 24 hours of admission, appear after 48 hours of admission. Infection acquired in hospital, but symptoms after discharge, when they go home. So all of you be silent. Team 1, your answer, please. Option? E. Okay, it's a wrong answer. Okay. Wait. No, it's not your way. Okay, it goes in Q. Team B. B. It's a wrong answer. Next. B. B, they have told it's wrong. No, you discuss and tell. No, I think it's pass. Next. Option D. It's all. Okay. No. Okay. C. Yeah, 4. 5. No, still they could have confused between the other two. So team 5 gets 2 marks. See, hey, the whole day they were telling 48 hours. Okay, so go back and read about it. That's it. What can I tell? Okay, now the direct question is to team 2. Okay, all of the following. This is about isolation. Okay, When a patient has this organism isolated in culture, they have to be isolated. Okay, question is not for you, don't take tension. Okay, I'll read out the question, okay, or I'll go here. Okay. All of the following organism needs isolation except MRSA, VRE, drug-sensitive Acinetobacter species, all XDR isolates, coagulase negative Staphylococcus species, tuberculosis, measles, varicella. Team B, second team. Yeah? E. Okay, correct answer. Next question is for team 3. MRSA and other multi-drug resistant organisms can be transmitted through medical equipment that is shared and not appropriately disinfected between the use, from the hands of the healthcare worker who do not perform hand hygiene as per recommended guidelines, through environmental surfaces that aren't properly cleaned, all of the above. D, all of the above. That's the correct answer. Team 4. Which of the following can be worn on hands during patient care? Ring, false nails, ring with stones, none of the above. Ring with plain ring. What is allowed? Yeah? 3. D, okay. Yeah, correct answer. It will come, it's just your turn, that's it. Okay, 15, team 5. Which color bag should you use when you dispose human anatomical waste? You think your question was difficult? No. At least 4 talks, 48 hours was mentioned. That itself, it was for team 5. So it was an easy question. Don't tell it was a difficult question. It was a definition of HI. All of you are infection control nurses? Huh? Okay. Team 6. How long should hands be washed for after wetting hands by applying soap? 30 seconds, 1 minute, as long as you feel, as you wish, or 15 to 20 seconds. 30 seconds, wrong answer. Question, pass on. No, you cannot raise your hands, please. It goes in turn. Yeah? 15 to 20 seconds, wrong answer. Last option, huh? Okay. Yeah. There is a different timing for hand rub. So only I have mentioned specifically soap. 40 to 60 seconds, that is 1 minute. Done? So don't worry, it's okay wherever you are there. We'll have one more round of multiple choice questions, okay? So team 1, don't get disappointed. You have another option. So coming to next question. It's a very easy question, okay? All of the following are device associated. All of you be silent. Take your own time and answer. Okay. All of the following are device-associated infections except CORTI, CRBSI, ventilator-associated pneumonia, surgical site infections. Please silence. Device-associated HAIs. All of you be silent. D. Why surgical site infection doesn't involve devices, any surgical devices? Correct. So you've given a right answer. Okay. So maintain silence when the team is answering. It may confuse them. Okay. Team 2. Urinary catheter care bundle comprises, okay, closed drainage system, urinary catheter secure, drainage bag placed above the floor and below the bladder level, hand hygiene and meatal care, single-use glove, separate jug for color. All of the above. Yeah, right answer. So team 3. All of the following comprises ventilator bundle except head and elevation, adherence to hand hygiene, oral care with chlorhexidine, DVT prophylaxis, close suctioning. Close suctioning, sure? Okay. Why not close suctioning? Isn't it a good practice? Yeah, it is a good practice, but it's not described under bundle. Yeah. Team 4. Which of the following needs airborne isolation? Tuberculosis, MRSA from blood, influenza, meningococcal meningitis. Team 4, right? Yeah. Yeah? Tuberculosis, yeah. You're telling in doubt or? Influenza is not airborne. COVID? Okay. So tuberculosis is the right answer, but may I request Divya ma'am to add a few points on isolation?
So tell me, why not influenza? What is influenza? I mean, what isolation? You have a patient of H1N1, who would you isolate? I mean, where would you isolate? What is the precaution you will take? It's not negative pressure. So, but what is the kind of isolation? Here we have written airborne. What is the other isolation which is described?
Contact isolation.
Yeah.
Droplet isolation. Yeah. So basically, airborne isolation, what you say, so when the patient coughs, they transmit very small droplets, okay, which will still be suspended in the air. Okay, so that is why it is called airborne. So that is where you need negative pressure isolation, because it has to exchange the air to actively put the organism outside. So droplet is where when you cough, it falls down, okay, because of the size and weight of the droplet, it will fall down. So that is where you just isolate them in a separate room, and surface cleaning is enough, because they are droplets which are settled on the surface, okay. So that's where you need surface cleaning. The other one is contact isolation, which we do for all the XDRs, what is mentioned, MRSA. All those are transmissible by contact with contaminated surface. So there again, you need to isolate them separately, but the the regular surface cleaning is the main mode of decontamination. Okay? Anything? Any doubt?
So what are the 3 types of isolation? Yeah, take home message. Remember when to isolate your patients. If you Google type it, you will get the whole info about it. There's an article about it, okay? And implement it in your hospitals, okay? Next question to team 5. One second. All of the following are transmission-based precautions except contact precaution, droplet precaution, standard precaution, airborne precaution. What do you mean by standard precautions?
It will be happening everywhere, like touching the patients and handling your instruments.
Yeah, it is something which you follow regularly, irrespective of their positive findings. Okay, very good. Notes. Team 6. Which of the following is a vaccine preventable occupational bloodborne infection? HIV, hepatitis B, HCV, varicella, and other combinations. Which is your option? Vaccine preventable occupational, there's a question, there's a mistake here. Vaccine preventable infection, that's it. Not bloodborne, there is a correction here. Yeah, no, 1 second, let me edit it. One second. Yeah, which of the following is silence, please? Silence. Which of the following is the vaccine preventable infection? Yeah. Yeah? If, what is it? B and?
Which one? Which is your option? D.
Hepatitis B and varicella. Vaccine preventable.
Yes. So you're talking about E. Option E. Hepatitis B and varicella is the preventable.
Yeah, this one. F option. Okay.
So what about HIV? We do give exposure prophylaxis and all. So why is HIV different? So can you prevent it before? So what Dr. Spurti has put are things that you can prevent even if you have sustained a needle stick injury. Okay? Even if, so varicella is something which you get from the patient, but hepatitis B is, vaccine is a single most important factor which can prevent you from getting hepatitis through your life. Okay? So a simple getting vaccine is going to save your life, considering that you will be hepatitis B for life. Okay? And as I said, HIV is a infection you can get through needle stick injury if you have one from a patient who is a source. But you still do have post-exposure prophylaxis, okay? But you know, that's not something you should aim for, all right? But hepatitis C, on the other hand, neither has vaccine, nor does it have any treatment, okay? So you get hepatitis B and if you get hepatitis C, you're done for life, okay? So you cannot, you will never know which patient has what infection, okay? So you cannot just assume, I have hepatitis B vaccination, I can take post-exposure prophylaxis. You never know what you get pricked with, all right? So you should always be careful. That is where standard precautions come in. You should treat like everybody has some infection, okay? So your precautions you have to take. I understand you serve the patients, but not worth getting the infection, all right?
Thanks. This is the end of multiple choice questions. Next round is buzzer round. I'll be displaying the question and I don't know, silently I want, don't make noise. Silently one of you stand up. Yeah?
But how will they know who's going to
Raise hands, we may miss. So one of you stand up. One who stands up first will get the answer. We'll get the chance to answer. Okay? Yeah, done? So I will stand away because time is very important for you. Yeah, done? Is it clear? It is, no. It is team-wise. The one who knows answer, the one who stands first will get the first chance to answer. If they are wrong, then I would go for next. Yeah, the one who stood second after them. So I request Sharon to note who stood first and who stood second, third. Only 3 options I'll give you. After that I'll answer. Okay. If none of you answer, the question will pass on to audience. Okay. Yeah. Stand. Who all are the audience? Oh, full audience only. Okay. So, be alert. First question. World Hand Hygiene Day is celebrated on. Please sit. Yes. She stood first. Huh? No. Group wise, no. Buzzer round. One who stands first. May 5th is right answer. Team 5. Yeah.
Maximum 6 people can stand, not 20 people. No, but everybody knows in that group, everybody wants to stand.
But the marks goes to your team itself.
No, but they don't know. They think you don't know. Only I know that they're going to stand.
Okay, fine. So ready for the next question? Would you like to come a bit this side so that they can come front? No? It's okay, fine. Be ready. Tick, tick. WHO theme on Hand Hygiene Day. Who? This team? Yeah. Huh? No, wrong answer. Wait. She stood. Yeah, correct. Good. So all of you are alert through the sessions. None of you were sleeping. Okay. Silence, please. Question 3. Ready? Sharon. Who is the father of hand hygiene? Huh? Okay, can you tell a few more words about Ignaz Semmelweis? It's the right answer, but just not. Hand hygiene, hand disinfection will reduce the puerperal sepsis. Great. Okay. So we'll go for question 4. Lot of fun, right? But I expect these 4 teams to stand up next time. First, when is International Infection Prevention Week celebrated? Yeah, October 3rd week. You're the right. Okay. Next question. Silence. Who is the father of antiseptic surgery? None of you know? Okay, fine. Audience? Option illa. Direct answer. Father of antiseptic surgery. So, father of antiseptic surgery is Joseph Lister, who insisted on disinfection of the surfaces, sterilization of the OT and all of it. Okay? Joseph Lister. Okay? Take home message. Remember him always. Next question. The last question of the buzzer round. Ready? Silence. When is World Antibiotics Awareness Week celebrated? No, I cannot tell you you are right or wrong. Stand up and tell the answer. Stand up and tell the answer. Somebody is doing Google check. No, no, the wrong answer. Please stand up and answer. No. She was telling that before you stand up actually. I was telling her stand up and tell. So give 1 mark. Anyway, you are Team 6. So big round of applause to everybody. So we really have a very enthusiastic audience. Nice. So next question is, no, we have image. No, that's not buzzer. That goes team-wise. Yes. It goes team-wise, not buzzer. Okay. See, it goes to team 1 first, and if it doesn't answer, it goes to team 2. Right answer gets 4 marks. The question pass will get 2 marks if whoever answers it correctly. Okay. I'm sure it's going to be easy. Don't worry. So I wish all of you get 4 marks in this. Okay, team 1. What's wrong? Please keep quiet, all of you. Recapping the needle. Second, what is the other point which is wrong here? Please. Yeah, holding in 2 hands. Correct. Team 2. What's wrong? I've kept it very easy, okay. Team 2. Please keep silent. When it comes to your turn, answer only then. If not, others will tell. Yeah, what's wrong in the image? Yeah. How is it supposed to be? Chin, yeah, it is supposed to cover the whole part. Correct. Okay, is it clear? Team 3, what's wrong? Why are you raising hand? Yeah. Yeah. Waste segregation is mixed. What is your description? What container? Stand up, be loud. Can all of you please be silent? All of you please be silent. Yeah, what is wrong? Describe your findings. Into a? Yeah, white, yeah. And which container is it in? It is in red. So this has all findings, all wrong findings. Very good. Next question goes to team 4, right? Okay. Interpret each one. Like, what's wrong? Yellow, is it correct? Red, it is correct or not? One of you can stand up and discuss. The whole of your team can participate, no problem. All of you, can you please be silent? Don't talk. Yeah? Red, be confident, be confident. Yeah, you're right, no problem, you tell. Who is answering? Only team 4 is supposed to answer. Oh, yellow is only correct, rest all are wrong. Yeah, right answer. Okay, next question goes to team 5. What's wrong here? No, all of you please be silent. Don't talk, don't whisper. can tell your findings confidently, loudly. Correct. Yeah. This was a very popular image during COVID times. Always follow cough etiquette. Either cough into your or sneeze into your elbows, or napkin or a handkerchief, or wear a mask all the time. Never openly sneeze or cough, because the infectious particles will spread through the respiratory aerosols. Right answer. The last question of the quiz goes to team 6. What's wrong? So a sister has sent, a staff nurse has sent like this in a pouch. Please be silent. Other teams are requested to be silent till they answer. After that, I'll give you time to share your experience. Huh? Yeah, you're right. Yeah, serum is spilt. The cap was not put proper from the ward, and the serum is spilt, and it has contaminated the other samples. First of all, we should not put multiple samples in single pouch. We should preferably put in different pouch, but it is sent like this, because of which the test is delayed, fresh sample is asked, and the patient is getting affected. Imagine it has come for procalcitonin. Again, whatever the sample collection, transportation, everything has to be repeated. So this is a question on that turnaround time. So this is the end of the brainstorming session. Yes. So here we are coming to an end on the infection control and prevention workshop. There were many sessions from morning. Actually, there are many more things and many more aspects in infection control, but it's definitely not a one-day activity. It itself is a 4-5 days workshop. In fact, few centers will conduct 6 months training on infection prevention and control. It is a vast topic by itself. It is boring, but once you dive into it, it is very interesting. Once you see your work is benefiting some patient, you will find it all the more thrilling, because all of us are healthcare workers. So we had Dr. Divya presenting about the basics of infection control and antimicrobial stewardship. She's the one who has all the guidelines in her fingertips. She guides everybody like anything. See, and what I want to tell is, always have an interaction with the laboratory team and the clinical team. Okay, because if you give a proper clinical history, like whatever is mentioned, while you are sending the TRFs, it would help to a greater extent to the laboratory personnel to interpret the results and give an accurate result. For example, if urine only more than 10 power 5 is significant, 10 power 4 colonies are not significant, we will not report it. We will report it as non-significant growth. But if we have a history of it is a pyelonephritis case or something, for some, if the patient is on antibiotic exposure, counts would have come down. Or if the patient is on diuretics, the urine will be diluted, then the colony forming units will come down. So if we have such important clinical history, it is easy for us to interpret and give a correct report. Had I known all these things, I would have reported that colonies. Because the count is not significant, I didn't report it. So the lab, not only for microbiology, even for pathology and even for biochemistry, it goes like this. Always give clinical history and talk a lot. Like when they ask you, please respond, and when you need some information, they would give you a better response. Okay. So go back to your hospitals, implement all infection prevention and control practices, and practice antimicrobial stewardship. I request Dr. Divya to address the gathering. Meanwhile, I will add. We don't have a tiebreaker, no? So we'll give only 2. Yeah. I request Dr. Divya to announce the quiz winners.
enthusiasm. At least, you know, it takes, I appreciate Team 5 for telling that there is nothing wrong, okay? You know, you'll always say it is right? If you say something is wrong, you'll search for the wrong, right? Just to say it is right, I mean, everything is right in that, you must be that confident to know that, you know, everything is right. So you know all of it, right? So that was the idea. So it is not about ruling out. You should not just say, this is not right, maybe third one is right. That's not how you should be trained. You should know what is the right, you should know what is wrong. It's not, you know, when you're giving treatment to patients, we cannot say maybe this will work, maybe this will work. You should give the right treatment, right? So even when you're delivering care, you should be 100% sure what you're doing. And see, nobody, I mean, I know you people are, you know, interacting with multiple doctors, you know, several levels of your management, but you know, it does not stop you from asking questions, all right? If you don't know, ask questions, okay? Just being ignorant is worse than being scared, right? So if you all are the leaders leading, then you should be approachable. So make sure that, you know, you're approachable to your subordinates. At the same time, you should be courageous to ask questions as well, all right? So I appreciate, I think everybody, you know, knew. I mean, if you got it wrong, it's only because you took the courage to, you know, take that chance, all right? I appreciate everybody for taking active part in this. And so we are unfortunately able to give only two prizes because the others tied up, okay? So the second prize goes to Team 2. Please come on stage and request, who's there? Selvi, come. Selvi is our nursing instructor who takes a lot of efforts to make, you know, nursing education easily available and, you know, make it easy. Good job, guys. And first prize goes to Team 5. Who to give? Dr. Spurti for her ever enthusiastic demeanor. Babu is not coming. He's not coming. Then it's okay. Ashtandilla. So I have to, so this is Mr. Arun. He is our quality manager and he's the one who's been behind us. Don't think we did everything. He was behind us and, you know, out of frustration from him, we did the work, okay? So I don't know if that's a compliment or not, but he took a lot of efforts. He spent a lot of time with us. I would like to request him to give a vote of thanks for us.
Thank you, ma'am. Good evening, all. Hello. Yeah. It has been a pleasure to have you here, all. So, Apollo Hospitals, from its inception, it has been a learning for each and everyone who has joined the hospital. So, on this infection control workshop, I hope we have learned new ideas and better experience has been shared among you all. So, I hope you're going to implement in your respective units. Our precious time flies like an arrow. We are getting to the closing time of our infection control workshop. At the end of this workshop, I want to thank Uday sir, Umesh sir, Gaurav sir and Rekha ma'am for giving this opportunity. and supporting throughout this event and make it success. So I thank all the speakers for the valuable contribution and the participants who have made the time to attend the workshop. I would like to take an opportunity to thank our sponsors for jointly sponsoring this event. And finally, I thank Divya ma'am, Eva and her team, and all our own staff for organizing this event and ensuring to run so smoothly. Thank you. Thank you. Thank you, ma'am.
Okay, it's been a great ride. See, honestly, we didn't know we are going to get such enthusiastic bunch of people. I think you should take the enthusiasm back to your hospital and please, at least 10% of what we have told, go back to see what we have told and implement it. And if there's any suggestion for us, please let us know. If there is something that we can implement, please share with our infection control nurses, Eva and Sharon. And you can ask them doubts, or you can ask them how we do certain things. If there's any better way you're doing it, please share with us so that we can also implement. All of us are in the process of learning. All right? Thank you.
Hello, excuse me. Can everyone have one group photo?